We start with Baylor College of Medicine, Dr. Goodman. Dr. Williams.
Present.
Okay. At A&M, Dr. Liberzon. Dr. Harper.
Present.
Okay. From Texas Tech, Dr. Wakefield. Dr. Trevino.
Here.
Okay. Texas Tech El Paso, Dr. Thompson.
Here.
Dr. Martin.
Here.
From University of North Texas Health Science Center, Dr. Polowitz.
Here.
And Mark Chassé.
Present.
From Dell Medical School, Dr. Nemiroff.
Here.
Steve Strakowski.
Here.
From MD Anderson Cancer Center, Dr. Tan. Dr. Robert. UTMB, Dr. Wagner.
Here.
And Dr. Vo.
I'm here.
From the Health Science Center in Houston, Dr. Suarez. Dr. Newland.
Here.
From UT Health Science Center San Antonio, Dr. Plitzka. Dr. Blader.
Present.
From UT RGV, Dr. Escamilla. Mr. Patriarca.
I'm here.
Okay. From UT Health Science Center in Tyler, Dr. Matthews.
Here.
And Brittany Nichols.
Here.
And from UT Southwestern, Dr. Tominga.
Here.
And Dr. Ibrahim.
I'm here.
Okay. From HHSC, Sonny Gaines.
Here.
Okay. And Mike Maples. From the Higher Education Coordinating Board, Dr. Silberman. Representing the hospital systems, Ms. Wesley.
Present.
And Andy Keller. He's not here yet. He's going to be in just a little bit. I think Shannon is going to be sitting in for him for the first part of the meeting. From the Hogg Foundation, Octavio Martinez. Octavio, I saw your name. All right. He'll be here later, I think. From the Mental Health Council, Danette Castle.
Here.
And I'm here for UT System. And then Dr. Borges.
Here.
All right. Well, we'll count that up, but we have a quorum. And so why don't we go ahead and get started?
24.
What's 24?
No, I'm here, Steve Pliska.
Steve Pliska's here too. Good.
Just join.
And Dr. Wakefield. So so anybody else that didn't respond to their name, I have Dr. Pliska, Dr. Wakefield, anybody else?
Dr. Lieberson.
Jair Suarez here.
Dr. Suarez?
Yeah.
Israel Lieberson is here.
Okay, good, Israel. All right, very good. Anybody else? Hearing none, why don't we go ahead and get started? First item of business, we need to approve the minutes from the last meeting. If
So
everyone can
moved.
take a second and take a look at it.
So moved. This Wiltz.
Dr. Podowitz, we have a motion. Do I have a second?
Second.
Second from Dr. Liberson. Any further discussion? Hearing none, all in favor of approving the minutes from the last meeting signify by saying aye.
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 Opposed, nay. Anybody abstain? Hearing none, the minutes are approved. So a little bit about the meeting today. We're going to spend the first part doing a quick review of where all the projects are in their current status and the other components of the consortium, the evaluation, communications, in addition to the main buckets of work that we're working on. We're then going to spend a little bit of time hearing from another state about how they have built upon their CPAN to serve moms. It's not something we can do right now, but something that we want to make sure that we understand well, especially as we go into the next legislative session, to make sure we understand the possibilities of addressing other health issues here in the state of Texas. Following those discussions, we're going to spend some time with an update on the COSH and the work that's taking place, and then spend quite a bit of time talking about budgets. I want to thank everyone for the time that you've put in place in order to refine your budgets. We're still getting some information back from several institutions right now. Lachelle has done just tremendous work trying to get this information correlated. And so I want to thank her and thank the rest of the team. We may not have all the information we need to make some decisions, but I think we can give a good picture of where we are right now related to expenditures and some of the priorities that institutions have brought before us. I want to think with you related to what we can do with some of those unexpended funds. But with that, why don't we go ahead and jump into the quick updates on the projects. Daniel Oppenheimer from our team, you want to talk about the communications?
Yeah. I just wanted to show you, we're sort of moving forward on the next iteration of the website. And I wanted to actually, let me show you this first. So at some point in the next few weeks, we just have a few technical things we need to solve. We're going to transition over to a slightly updated website, which will have a different URL. And it's pretty similar to what what's up there already, but it's a different content management system that's going to allow us more flexibility. So when I'll send out emails when that's ready to go live, but it's essentially the same as the previous one. There's now a news section where we can link out either to content that we produce or to articles or press releases from other institutions. And there's a little bit more on each of the initiatives, just taken from the one-pagers that we've done or other institutions have done. So we're going to move over to that at some point, probably in the next few weeks. That's kind of version 1.2. And then I just wanted to show folks, just so they're in the loop on what we're doing. We're working on 2.0. I know some of you have spoken to our UX UI designer who's been doing some interviews just to understand what we want in the next iteration of the website. And this is a draft sitemap that we're working on, which just shows the basic architecture of the site that we're planning. So it's not a radical change from the current sort of navigation structure, but we're breaking out CPAN and TChat up in the top level navigation. That we're not going to call them that because sort of to be most accessible and sort of immediately processible to users, we just want to sort of describe it by the nature of the initiative rather than the acronym or our sort of bureaucratic name. So something like we'll have a category for primary care providers, one for schools, and then we're going to create a learn category, an engage category, and then we'll keep the about the consortium. So I just wanted to show folks to that, and as we get more further along on that 2.0, which we want to roll out in the next few months, I can show you more pieces of it. But if anybody has any questions, happy to talk about it, but just want to make sure you guys were up to date on that.
Any questions for Daniel?
I like it. Good work, Daniel.
All right.
Okay. Thank you. Yeah, we're moving along, and thanks to everybody who's been sort of participating and helping us kind of develop this.
And Daniel, is there anything else besides the website? I know you worked with several folks to put another release related to the current status of CPAN out and a couple other things.
Yeah, that's right. So we just issued a release. Well, UT System put out a release about the kind of launch of CPAN and TChat. We put one out a few months ago when CPAN kind of technically launched, but we wanted to put out another one just now that CPAN is up and running and has been taking calls and the school year's about to start, or in some cases has started. So T-Chat is being implemented. So that's out there. We're going to do a few things to promote that. Folks are also welcome, if you want to get in touch with me, to sort of put out basically the same release or some modified version of it from your institution if you want to kind of boost that signal. I'll just say, but I've talked about it before, is I know some folks have been using Canva. We've been making some modifications to it just in response to people's needs. Most of you have given us email addresses to access it, so you have a registration and password to access it. There's a few who haven't, which I assume means it's not urgent, but I may reach out to you and just make sure we have an email address that we can generate an invite to for Canva. And also, I just maybe one last request. I know some of you are continuing to produce your own materials, which is great, sort of independent of Canva. But if it occurs to you to share those with us, that would be great, because I think one of the things we're going to do is, as institutions produce their own materials, we can take them and adapt them so the other institutions in the consortium can use them as well, with modifications for their own activities. So if you have new stuff, please send it on to us. We're not asking for approval, or we're not asking you to wait on our approval, but just let us use it so we can share the wealth with the other institutions.
All right. Any questions for Daniel? Hearing none. Thank you, Daniel. Why don't we move on then to the program evaluation by the University of Texas at Austin. Molly, are you here?
I am. Good morning, everyone. We've been working diligently with the data governance group and the CPU group. And I believe a lot of the work that we've been working on is going to be presented within those groups by those chairs. So I think for the sake of time, we'll just pass our time along.
All right. Thank you, Dr. Lopez. Let's move on then to the external evaluation. Nagla Ilarian from our team will give a quick update.
Sure. So the RFP submissions have been extended for another week due to the storm that we had last week. So it's been extended for a week. There's also some questions and answers that were posted on the site. And so if you go to the site of the RFP, you'll find those Q&A available. And that's pretty much it. So that it closes the end of this week, or I think Monday of next week.
All right. Any questions for Nagla? All right. Thank you. Let's move on then to community psychiatric workforce expansion. Dr. Plitzka, do you have an update? Oh, you're on mute.
Could I bring up the minutes that I sent in? They're in the packet. They're attached to the list of everything. It's like a 2-page document. Here it comes. So the workforce has been focused recently on refining the metrics that we're using, and I believe we're part of the legislative budget board packet and are in everybody's program definition documents. In table 1 there, you see the general metrics, and what we've been working on is kind of operationalizing them. And to be brief, basically 1 is very straightforward. 2 through 5 can be assessed by pulling data from the databases that the LMHAs and HHSC obtain routinely. And the people from HHSC and the LMHAs have been very helpful and kind of really working on their own to developing that for us, and that's well along. Now, there are 2 things I want to mention that I think the consortium may need to take some action on. On item number 6 in tracking metrics, if you would just scroll down a bit to that bullet point, there we go. So this was looking at the number of people that were referred into the CPWE from CPAN and TChat. And we determined that the most efficient and easiest way to do this is basically have CPAN and TChat simply record referral to the LMHA as one of the dispositions when the person's time in that program has ended, rather than trying to have the LMHAs independently track who is coming in from TCHAT or CPAN, because that would require families remembering to tell the LMHA that they were being referred. Once they come into the LMHA, they wouldn't necessarily go into the CPWE program. So I think from our purposes, the spirit of that metric is that we want to show that we are making efforts to connect our CPAN and TCHAT projects with the LMHAs as part of a process to make sure people get the longer term care that they need once CPAN or TCHAT have intervened. That's basically that's the recommendation of the task force to the consortium, and actually was going to kind of obviously refer that on to Kosh for further consideration. And if we go down to the performance metrics,
Can I ask a question?
Sorry.
So can I ask a question here?
Sure.
Steve, my question has to do with the conceptual value of these metrics. So assuming that CPAN is functioning well and we have a good, very good primary care pediatrician and really good consultants, why would they refer? I mean, it will be a lot of the work will be contained within the CPAN or even TCHAT, and maybe less referrals to local mental health. So to me, it's a little bit of a number that kind of can be, so sometimes small numbers can say very functional CPAN, or and big numbers could say dysfunctional CPAN. So how do we really rely on that metrics, or how we think about this metrics?
Well, the practical issue is the metric was put into the LBB and we have to track it. And so what we're trying to do is operationalize it in the most practical way possible.
So we did not decide on this metrics. That's what you're saying.
Right. Well, though we as a group decided on the metric and we voted on them and they went into the LBB, and now we're starting to think about what they mean and how to do them. But it is, joking aside, it is assumed that kids in either TCHAT or CPAN, there's going to be some individuals with serious mental illness who probably are going to need more intensive intervention and won't be able to be managed purely by the primary care doctors, and will need more extensive intervention once once TCHAT is complete. So this is a way of saying this is how we dealt with that situation, and it presumably in looking at the data should correlate with having more severe illness as a measure, that probably kids with straightforward ADHD continue to be managed by the PCP. Kids with bipolar disorder and intellectual disability probably end up being referred to LMHAs. That's the sort of thing that we're ultimately seeking to do.
So, Dr. Plitzka, this is Danette. Would it really be fair to say that as we were contemplating this in terms of a measure, that it wasn't really thought of as a measure that would, have a volume associated with it that we would think was either too high or too low, but really to be informed
Right.
about the process, about the fact that there could be the identification of young people who are in need of more comprehensive services, and just recognizing it's important for us to understand how that may unfold.
Correct. That's a very good clarification. All right. So we go down to the performance metrics. This is a little more complicated. The overall metric, if we could scroll down there a little bit. Oops, sorry, we're there a little bit more. Bring it up. I want to talk about metric number 2 briefly. So the general metric says that we will have an outcome measure. So we have had, because considerable discussion about this. Initially, we wondered whether the child and adolescent needs assessment, or CANS, in the ANSA, which is the adult equivalent of that, that is gathered every 90 days by the LMHAs. So we thought perhaps we could simply piggyback on that, extract that data. There were a variety of reasons that that's not advisable. One is that patients in the CPWE program may have interventions by other aspects of the program. The other is the sensitivity to change of this measure is not well established. And as a result, the work group voted not to use the CANS or the ANSA as an outcome measure. What we are proposing is that in a manner similar to TCHAT, we would obtain simple outcome measures such as clinical global impression, ADHD rating scales, depression or anxiety scales, basically the same assessments that are currently being developed for TCHAT within TRAIT. And I believe we're having a demonstration of TRAIT today. It would seem that the additional cost would be relatively minimal because we would not be asking for the development of a new outcome measure, but whatever outcome measures that are used in TCHAT, similarly, a patient could be enrolled in CPWE, in TRAIT, and those rating scales sent out in exactly the same fashion. So that's what we are proposing to the consortium. Whether you want to have a discussion now and a vote on that, or wait until our cost discussion, I'll leave that up to the chair.
I'm happy to do it either way, Steve. If you want us to vote and discuss it in more detail now,
okay,
that is fine, or we could do it later.
So
maybe
let me give a little more detail what we have in mind. So as the COSH committee also saw the demonstration of the TRAIT a little earlier last week, and it looks like that basically there are ways in which parents can be emailed in a secure fashion various forms of rating scales. The clinician selects the rating scale to send out, and then the data is collected back. So what I propose is the CPWE clinicians, the residents and the faculty, would do exactly what they're doing in TCHAT. They would say, your child's being treated for ADHD. I would like you to get Vanderbilt, and it would be sent out to them. And we would then be able to collate that data in a fairly straightforward way. So by doing that, the burden does not fall on the LMHA personnel, and gives us, I think, a set of data based on the people in CPWE that we've worked with. So our thinking is there would be sort of minimal development costs, relatively low burden on the clinicians and the families, and we would get data that is specific enough that it would address the outcome measure.
Why don't we pull in Laurel and then Danette into the conversation just to make sure we understand their perspective, and then we can decide how we move forward. Dr. Williams, are you there?
Yes. Can you see me?
Yes.
Can you hear me? Okay. So for the first question about CPAN and TCHAT, we already do have built in, for CPAN definitely, in the referral section that you'll see later today, that a referral to LMHA is included. And actually, I think we have a drop-down menu of all the LMHAs, it can be a little more specific. So we are going to be able to do that. In TCHAT, we had the same plan that as we do a build-out for TCHAT, we would do the same thing. When it comes to using TRAIT for the measures, I think my biggest concern when I was talking with Dr. Pliska about the other day was whether or not the LMHAs themselves would find that having their families have to do yet another thing would be something that they would be excited or not excited about. So I was more hesitant in wanting to find out a little bit more from their teams what they felt would work best. I know that with the CPWE, we have, clinical faculty from our HRIs involved. And so maybe that would be a reason that it wouldn't be as a challenge, but I think that was my only concern, was that they already have families do things and whether or not that would seem intrusive.
So I can't, of course, ever speak for everyone in our system, but the feedback that we got was that the approach that has been now recommended by the group is received more favorable feedback. So I think they were feeling as though this would be the best way to gather feedback and, you know, maybe even start to head us in a direction of being able to capture some care experience at some point, so that it actually can be linked to the resident that is providing care. Comparing that, of course, to the other option of using the CANS or the ANZA, which we really got, you know, feedback as Dr. Plitzka described, that it would not be the best approach.
Okay. So it sounds like there's consensus from Dr. Williams, Danette, and Steve to go in this direction. Danette, do you need any more conversations, or you feel comfortable? It sounds like you feel comfortable with moving forward in this direction, right?
Yes, we do.
Okay. So Steve, do you have a motion then? You'll make a formal motion?
I move that the tracking metric number 6 and performance metric number 2 be operationalized in the manner described in these minutes and as we've discussed.
Second.
I have a second from Carol.
Yeah.
Any other further discussion? Hearing none, all in favor of moving forward as directed and changing this metric, signify by saying aye.
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 Aye. Aye.
All opposed, nay. Okay, I didn't hear any nays. Any abstains? Anybody abstaining? I did not hear anybody abstaining, and so it sounds to me like we have unanimous approval to change that metric.
The work
in
group
the way that Dr.
All right,
described.
and that's all I have.
Okay. All right, very good. Let's move on then to the Child and Adolescent Psychiatry Fellowship Program. Dr. Newland?
I sent an update to Luann. I think we had, I had a report from everyone, and I'm hearing that the planning grants are going well. I've heard from Sarah that it was representative. It looks like y'all are planning to have 2 fellows in 2021. Is that right, Sarah?
Is the plan, are you talking to Sarah Martin or Sarah me?
You.
Yes, that is the plan. We are planning to resubmit our accreditation packet on in November, and then have approval in the early spring and go from there, is our hope.
Great. I wanted to take a minute just to check in with UT Austin. I wasn't sure, I hadn't heard if they were also wanting to have a planning grant or if there was any update.
Thanks, Elizabeth. Yes, I don't know if Dr. Coley is on the call, but yes, we're very interested in taking part. We just were hoping we weren't too late. So Dr. Coley sent an email to Plitzka this morning concerning our desire.
Now,
still room in
is that
the
to
budget.
be in the CAP fellowships or the CPP?
In the CAP fellowships.
Okay, that's under Liz. I'm under the LMHA expansion.
So Dr. Coley inadvertently sent it to Dr. Plitzka.
Oh, no problem.
But I will forward, or Steve and I will forward it to you. Thanks.
So Charlie, Dr. Nimroff, what would be your timeline? When would you want to start that fellowship?
Start for the July.
July of 2021?
Yes.
Okay.
Dr. Nemiroff?
Yes.
I've
Dr.
spoken with Dan.
Dr. Coley is on the call, so perhaps since she's much more on top of this than I am, she can weigh in here.
Sure. Dr. Newland, my apologies. I should have sent that email your way this morning, but I'd be happy to have a discussion with you afterwards. I think, we are in a good spot in terms of where we are with the Child Psychiatry Fellowship Program with the addition of new faculty and good, robust programs that I feel confident that we could provide a really good educational opportunity.
Mhm.
So, no, that sounds good. I'm just trying to think through the finances of it. If you start in July of 2021, you basically would be asking not only for the planning grant, but also the dollars for the fellows for 2 years. How many fellows are you looking at starting next year?
So through this, we were just looking at one additional fellowship spot.
So were y'all wanting, do you already have an established child fellowship at UT Austin? You were just looking to add a fellow then?
Yes, right. They don't need a planning grant.
Yeah.
They don't need a planning grant.
No, we do not need a planning grant at all.
Yeah,
So you're looking for one-time funds for one additional fellow. So that would be a $150,000 or so ask.
That's correct.
One-time, right?
Yes.
Thank you, David.
So that we'll put that on our list of other requests for the consortium as a whole as we go through our discussion today. But it's good to know that. It's not a planning grant. It is to add one fellow and something around $150,000 for total costs.
So it's a +1 ask.
Okay.
Thank you.
All right. Thank you. And I don't think we've checked in with UT Rio Grande Valley either recently. I think be good to hear from Dr. Escamilla if he's on here about their planning grant.
Yes, yeah, we're on track. We're submitting the full application and hoping just to have fellows start in July, 2 fellows.
Wonderful. All right, that's it for me.
And that's already budgeted in, right? And then UT Tyler is also thinking about a planning grant, but they are starting in July of 2022. And so that would be dollars we need to secure next session. Nicole, or Brittany, anything that I said wrong there or anything you want to add up on that?
No, I mean, I would confirm with Dr. Matthews as well, but we are planning 2022.
Okay.
Correct.
All right. Very good. Why don't we go ahead then and move on to TCHAT. Dr. Wakefield, you have an update?
I think we have deferred giving updates from our committee to the COSH.
Okay, yeah, that's fine. And Dr. Williams, the same thing for you or anything else you want to add now versus later?
No, later is fine.
All right. And then on the research initiative, again, kind of brief, but quick update. Dr. Nemiroff, anything?
Yep. Everything's gone really well. Dr. Newport is also on the call. The major issue for us is getting the IRB approval. And Carol and Maduka might speak to this. Everything has been submitted. We're in the midst of node training. The nodes, by and large, have been terrific. We've been training them in groups of 3. We have a hierarchy of sites that are more ready than others to get going. We're fundamentally ready to launch. We're just waiting for the final IRB approval. Carol and Maduka have been terrific in helping the UT Southwestern IRB work with each of the nodes to get everything done. So we're sort of chomping at the bit.
All right, very good.
Thanks, Charlie. I think that it's getting very close. At least from what I can tell, that because we kind of fortunately changed the system a little so that it directly deals with Jeff and your team so that there isn't a delay. And so that took a little time, but I think you're on track. We can check back, but I think it should be coming if not today, tomorrow, this week.
I think things are going really well from my point of view too. I'll check on the IRB today.
Okay.
I did have a question related to the research initiative. Some communication that Lachelle sent about distribution of funds. Do we have an update on that? Because that is when sites are trying to get these programs up and running.
So that's a good question. And I have the same question, Sarah. So apparently David, apparently the funds are still at UT System and they haven't been distributed, at least to our site. And some of the other nodes have asked me about this as well. So this is way above my pay grade. Maybe you and Luann could sort of weigh in and give us a heads up.
Yeah, absolutely. Lachelle's been tracking this down with the Higher Education Coordinating Board. And so let me allow her to give you the most up-to-date information.
So we've been working with Ken over at the Higher Education Coordinating Board. As soon as we receive the executed PIA amendments, we send them over to the coordinating board. We don't have the funds, the coordinating board has the funds, so we rely on them to do the transfers. Last communication I had with him, he still hadn't done the transfers. He was aware that it needs to be done. I think because we're so close to the next fiscal year, our intention was to give him everything for both FY20 and FY21. He already has 20, but we're going to go ahead and give him 21 and ask that he do the whole whole budget for the biennium in one go. It sounds like it's a bit of effort on their part to get these coordinated and sent over. He mentioned that they were busy doing their own budgeting, but he is aware of it. We've provided the information, and we've been following up very regularly. But at the end of the day, we rely on them to do the transfers.
Any other questions for Lachelle? Dr. Iskamia,
you want us to go ahead. Sorry, Steve. You want us to go ahead with hiring and executing. This is just a kind of behind the scenes thing, like hiring research assistants and getting.
Yeah, I think this is all behind the dollars will be approved. We just they're just bogged down like a lot of folks with the end of the year.
Okay.
Michael Escamilla, your hand's still up. I may have missed you earlier when we were talking about the fellowships. Was there anything
that was fake? I just took it down.
Okay, very good. Thank you. All right. Dr. Trivedi, anything that you want to add related to your hub?
I think then Sarah can add. I think yes. We are with Charlie. We have finished all our trainings. All the nodes are ready to go. The first participant, thankfully, at least for that one at UT Southwestern, IRB is approved, and we did enroll the first participant last week. About 4 nodes are about ready to get IRB approval this week. So hopefully this will start rapidly. We've had our committee meetings regularly. So things are moving as planned. I think I can show you the chart we had developed about our targets. I think we are meeting all those. And hopefully this, starting in September, which is this month, we should start getting enrollment rapidly going in most places. We've set up recruitment processes, etc. The committees, including the recruitment committee, extramural funding committee, and the measurement-based care committee have met. And so my sense is we are very rapidly moving to the large-scale recruitment process and monitoring. Database has been set up like with Charlie's also.
Okay.
Sarah, anything you would add?
I don't think so. I mean, we did, Dr. Trivedi, you did a great presentation, but I think you encapsulated everything in that PowerPoint. So I don't know that we need to go back through it. Just that there have been concerns from sites that they couldn't go ahead and hire. They were getting feedback from their administrative arms of they can't hire if they don't have these funds. And that goes along with, I communicated with Lachelle. how many HRIs are having difficulty with that? It would be nice to know. And then if we could provide some guidance that said, yes, you can go ahead and hire, these funds are there, they're coming. My HRI, just because of they're relying on operating policies that exist, that don't adequately encompass what we're trying to do here. And so was told, you know, we can't release funds until we have an approved IRB. So just a little bit different than typical grant related funds, but there's not really a mechanism at the HRI to do this without additional guidance. So I didn't know how many other people were having that issue. And if there was a way we could be helpful as a research committee in developing some guidance around these dollars.
Any comments, Dr. Trivedi? Any?
I think are you talking about the money received by nodes, Sarah? Maybe I.
Yes, or I mean, they haven't been received yet, but yes, the monies that when they're received and that kind of thing. Anybody else having, Dr. Trivedi, I know in some of the calls with the people, several HRIs have communicated concerns related to that.
Right. I think a lot of the HRIs, unless there is money already there, are having to justify and not succeeding in getting people on board because they can't hire if the money is not already there. So some of the HRIs, even the promise that it's coming is not sufficient. And so that, but as Lachelle says, it sounds like that is moving, but we're not totally in our hands.
Just a comment here. Really, we cannot help anybody with that, us, because the fiscal policies of each HRI are written into their bylaws, and how the disbursement of funds occurring on the level of HRI have very little to do with any consortium, and HRIs are not very flexible in the way that they change their fiscal policies based on any specific events. So I wouldn't even try that part.
Well, and the reason I brought that up, Israel, I think it's helpful for your perspective as well, because that may be many people's experience. But our HRI in the Office of Sponsored Programs definitely communicated that additional guidance would be helpful, because without additional guidance that they're relying on existing operating policies that don't really apply in the same way. And so that's why I brought it up. But it may not be helpful to every HRI, but it was communicated that it would be helpful to ours. And so I thought maybe other people were in the same boat.
There are some, yeah,
so Sarah, let me just explain that what most of the nodes are trying to do is to go ahead and hire the research staff that they need using either startup or other funds that are available. And then you use the consortium funds when they come in, and then journal back to support the funds that you've laid out. This is something that, you know, Israel, Maduka, Carol, Jair, Karen can tell you we do on a routine basis all the time. When NIH funding is expected, but it's not here, we go ahead and hire people, and then we pay that fund back. In the event that there are no such funds, then that's obviously a problem. But Israel's right, we can't change the university policy.
At UT Southwestern, I can just add that at UT Southwestern, if for instance, for a federal grant, once we get a funding notice, even though money hasn't come along with it, once we get a funding notice, we can spend on that. And I think we have the equivalent of a funding notice for this research. And I would guess, and David could help us with that if we need something more. So that you could just say Sarah, you could just say that this is done at other places like this.
But Charlie, I think the issue has been at some of the HRIs, we do it all the time, but I think some of the HRIs have not exercised that approach. And so their sponsored program group is not allowing them. And that is what the issue is.
Sure.
Well, and to be clear, we're definitely working out things here and everybody's working as a team to do it. The reason I bring this up is that it's been communicated in several different nodal meetings, not just here, and that the communication to me was that these funds are coming in a little bit different way than other funds have come and without specific guidance. And so I just thought, if we're going to continue to do this in the future, which I would like to do, that maybe it's an opportunity to develop some guidance for the HRIs in the future.
I think so. I think what Sarah is saying is this notice of award example that Carol gave is really the procedure and the method has been established in some of these places for federal grants, and a similar thing for the state institutions may help in the future is I think what Sarah is saying.
Yes, thank you.
Okay.
But the good news, I think, is for at least, and we are on calls with Charlie also. I think all the nodes, none of the nodes have said we are not participating. So the good news is this is going forward. People are excited, and I've been extremely thankful to everybody who's really been responsive for too many meetings we've had with each node. So thank you all. And you know who you are, Israel, and all.
It's been a fabulous group effort, and we don't want to waste the time of the entire consortium, but you know, we could shout out a lot of people here, but Michael Escamilla has really stepped up in terms of helping with the translation. Israel has served tirelessly on a committee that's looking at data management as well as add-on projects. It really has been a wonderful effort. Shauna Clark has been fabulous in our biostatistics core. So it couldn't be going better. And it's a lot of work.
All right. Well, thank you all for that update. And we'll work with the Higher Education Coordinating Board to see what we can do to make sure things are moving as quick as they can, understanding their current situation that's going on. So why don't we go ahead and move to agenda item number 4. And let me give you a little bit of background on this item and why I put it on the agenda for today. I think it's really important for us to look around the United States and see what other states are doing and learn from them on how they're addressing these issues. One of the top priorities for the state of Texas and for the legislature has been postpartum depression. I think there's some opportunities for us to leverage what we're putting in place to address this really important issue for the state. Now, we will need to get legislative direction before we spend any of these dollars that we have to be able to address that and to shift. Again, with any of these, we're trying to hold fast to what the statute says we can and cannot use the dollars for. But we also think there's an opportunity to have this conversation and think about next legislative session. And if the elected leadership of the state wants us to build upon CPAN, that we're ready to do that and know the experience from other states on how they did that. And so this is more informational and more strategic thinking for the next session and after the session than what we're doing right now. But one of the states that we've been learning from has been Massachusetts. And so we have Dr. Nancy Byatt, who is from the Massachusetts Child Psychiatric Access Program for moms. And so they built upon their CPAN program, a specific program for moms. She's the medical director of that program and is an associate professor of psychiatry, OBGYN, and quantitative health sciences at the University of Massachusetts Medical School. They call it MCPAP. So for moms, the Massachusetts, the Massachusetts Child Psychiatric Access Program for Moms. So MCPAP for Moms is a program that addresses postpartum depression as well as co-occurring mental health and substance use disorders. It was developed in 2014 and has been shown to be an effective program at improving outcomes and engaging women needing services through different programs. again, that their program is similar to what we are putting in place, but with that added component to provide support to OBGYN providers, pediatricians, and also that I learned some other psychiatrists as they try to facilitate the ability of postpartum services. And so, Dr. Byatt, are you here?
Yep, I'm here. Can you hear me?
Yeah, I can. And so I'm going to turn it over to you. Thank you again for being here, being part of this conversation, and look forward to learning about what you guys are doing.
Yeah, thank you for having me. Let's see, I'm just going to try to share my screen here. Oh, it's asking me lots of questions. Let's see, I don't know why it's asking me like 50,000. You know, maybe Nagla, you could share it because it's not, for some reason, it's not letting me share my screen. Let me just try it one more time. Yeah, I don't know why. It's not letting me share my screen for some reason.
So we'll see if we can share it from here.
Yeah, because you have my slides right now, Nagla, so maybe we should yeah, I think that's easiest. I don't want to be messing around with trying to get this to work. So if you share it, then I'll just tell you when to advance the slides. Can you put it in the slideshow, please? Thank you. So it's a pleasure to be here. So I'm Nancy Byatt, and as you heard, I direct I founded and I direct the Massachusetts Child Psychiatry Access Program for Moms, which you call MCPAP for Moms. And I also actually do a lot of research in this area as well. And what I'm going to talk about today, next slide, please, so what I'm going to do is describe the development, implementation, and outcomes of MCPAP for Moms, which is our perinatal psychiatry access program in Massachusetts. Next slide. And then what I'm going to do is outline how it's being implemented throughout the United States. Next slide. And provide insights that will hopefully be useful to Texas stakeholders, meeting all of you, for contemplating such a model in your state. Next slide. So mental health conditions are the most common complication of pregnancy. And, you know, in the postpartum period, it's interesting because you mentioned postpartum depression, and we actually think of this as perinatal depression because of women with postpartum depression, 2/3 of those women actually enter pregnancy with pre-existing illness. So we think of this as perinatal depression, and most of our work is around that. Next slide. And it's well established, it has a negative impact on mom, child, and family. And I won't go into the details on that. Next slide. I do want to point out that, so we know this has a negative impact, and the vast majority of perinatal depression is under-recognized and untreated. So our group did a systematic review, and we found that even if a woman screens positive for depression, less than 1/4 of those women are going to get even to an initial mental health assessment. Next slide. And we also know that this is not only does it have a negative impact in general, but it's a leading cause of preventable death in America. And it's on par with infection as being the leading cause of preventable death. Next slide. And of those preventable deaths, this comes from the morbidity and mortality review committees that are run by the CDC. 100% of those pregnancy-related deaths related to mental health were determined to be preventable. Next slide. So clearly, it has deleterious effects. The other thing I want to point out in the midst of the COVID-19 pandemic is that it's increasing perinatal depression anxiety, which, as I mentioned, occurs in 1 in 5 women, and it's increased during the pandemic. So depression has been, studies are showing it occurs in 1 in 2 and 5, and anxiety as high as 1 in 3. And it's also widening health disparities. Just to give an example of this, I had a patient that I saw recently through MCPAP for Moms, and she, you know, the OB called me, and the patient was worried that she was going to die in childbirth because she's aware that she was actually Latinx, but she said people perceived her as being Black, and she thought that, you know, I'm more likely to die in childbirth because the providers are going to perceive me as Black, and I know that Black women are more likely to die. And this is something that we're seeing more and more in our program. So, and I'll make some comments later about how we're also addressing that. But next slide. So people are recognizing this. It's being recognized, perinatal mental health is being recognized as a major public health problem. And lots of professional organizations are recommending screening and are recommending that this gets integrated into maternal and child health care settings. almost all the recommendations, however, say, yes, we need to address this. And most of them they're all recommending screening. They're almost all recommending doing this in the context of a system in place to actually help providers to be able to respond appropriately and adequately to a positive screen. Next slide, please. And so in general, the perinatal time period is ideal for detection and treatment of mental health conditions. So every time a woman sees a provider is an opportunity to engage her in treatment and to screen her and to have that conversation. And OBGYN providers and also pediatric providers, really any provider serving pregnant and postpartum women, have a pivotal role in this process. Women see OB providers many times during this time period. And in general, most mental health conditions, especially depression and anxiety, are treated by primary care. So one of the goals of MCPAP for Moms and these other access programs throughout the country is to help frontline providers who work with pregnant and postpartum women to be able to detect, assess, and treat perinatal mood and anxiety disorders, and also substance use disorders. Next slide. So what MCPAP for Moms does, and also the other access programs throughout the country, their goal is to build frontline provider capacity to provide mental health care, thinking that that then provides a solution. There will never be enough perinatal psychiatrists or psychiatrists in general to see the pregnant and postpartum women that need them, especially given the increase in rates during the pandemic. So what these programs do is they aim to help the frontline providers do this themselves, thus increasing access to care. Just very similar to the child psychiatry access model. Next slide. So what happened in Massachusetts was, in response to the public health issue, actually the state wanted to mandate screening, and there was a lot of understandable resistance to that, because they didn't want to say, well, you screen, then what do you do with a positive screen? So instead of mandating screening, what Massachusetts did was they passed a Postpartum Depression Act, and that act created a commission. That photo is of Representative Ellen Story. She is the chair. She was the chair of. She's since retired of the Postpartum Depression Commission, and that commission was essentially charged with coming up with some sort of statewide initiative. And next slide, please. And in Massachusetts, we had MCPAP, which you have your child access program. All the programs in the country are modeled after that. We had MCPAP, similar issue, right? Not enough psychiatrists to see the kids that need one. People can call, speak with the child psychiatrist. The child psychiatrist hold the pediatrician's hand to help them manage the patient. So what happened in Massachusetts was, I was doing a lot of research in this area. We saw we had MCPAP. And so ultimately what was decided was to expand our existing child psychiatry access program to be able to create MCPAP for Moms. They increased the funding for the child program to create a program whereby we would provide these resources for frontline providers for pregnant and postpartum women, thinking that it's a similar issue with not enough access to care. Next slide. And that created MCPAP for Moms. So the MCPAP for Moms model is very similar in a lot of ways to the child model, with a few differences, which I'll explain. So there's three components: education, consultation, and resources and referrals. Those are the three core components. Next slide. And so I'll talk about education, that component. So what we essentially do there is we've developed training and toolkits really to help educate and engage frontline providers in addressing mental health. So on our website, we have a lot of resources. We also have developed algorithms, which these algorithms are publicly available and can be adapted for other states and healthcare systems. And then we go do, in the beginning of our program, we went and did grand rounds at almost all the birthing hospitals throughout the state. And then we also do practice level trainings at individual practices. We now also do webinars, and we can still go out to practices. Next slide. So that's the education component. Next is consultation. Next slide. So what we do there, this is really the primary currency, the engine of the access program. So we do provide that one-time education or component, that one-time training, and we provide ongoing trainings in addition. That, however, we know that education alone doesn't change provider behavior and doesn't change practice. So what I do believe, and what our data suggests, is that this consultation is what changes practice. Because what happens is the providers call us. At the beginning, they call with less complicated questions, and as they continue to call, we hold their hand, we help them manage their patients' mental health, and then they call and it becomes more and more complicated. So we have an 855 program throughout the that any provider in the state can call. They page us, they talk to one of our resource and referral specialists, they page the psychiatrist, we call them back, and we then provide telephone consultation. Next slide, please. So I'm going to give you a few case examples of how this works. So I'm actually on call today and for our program, and we just got I got a call this morning. An OB called and they said, the OB called and said, I have a patient and she's on 50 milligrams of Zoloft and it's not working. And I said, okay, well, that's probably not working because it's, likely she'd be on it for a year. And she's like, it's not working. I don't know what to do. And so we talked about, targeting, titrating to a therapeutic dose. And we talked about the different management strategies. Patient also wasn't in therapy, so we did a referral for therapy. So that's an example where they call, they have a medication question. We discuss that. They then go and manage the patient. Typically takes a few minutes. And as I mentioned in that case, she also, upon speaking, I learned that the patient didn't have a therapist. So we also referred to the community. People often call us just for a referral to the community. They may not need medications. It may not be indicated. So we often are doing a lot of referrals to the community. The other thing that we often do, to give you another case example, is we had a provider call recently and they called about a patient who had been on several different medications in the past, and they were concerned they were missing something. And we could have talked for an hour and I still wouldn't have felt comfortable, nor would the OB have been in starting a medication. So in that case, we recommend a face-to-face evaluation, which are all now being done through telepsychiatry. And so what we do there is we do a one-time consult. And one of the things I want to point out about these is that we often do these actually in the beginning, we were really doing them for, to help OBs do monotherapy with Zoloft. What we're doing now is we're doing this they're often calling us because the patient screened positive for bipolar disorder and they don't know what to do because it takes a long time to find a psychiatrist. So we're often helping them manage actually quite complicated patients with the understanding they do need a psychiatrist, but we help them manage them short term until we can get them into longer term care. And I want to make just note that MCPAP for Moms is different than telepsychiatry. People often equate those two models. We do telepsychiatry MCPAP for Moms since the pandemic. All of our our face-to-face consultations have been through either telephone or through video. However, a lot of telepsychiatry models, they're still providing direct care. We never provide direct care. We never prescribe we have a clear boundary that we are building frontline provider capacity. We never take over prescribing ourselves. And that's how we're different than telepsychiatry, because we don't actually ever provide direct care and we never prescribe. Next slide, please. So as was alluded to earlier, we serve all providers who serve pregnant and postpartum women. Next slide. Most of our calls come from obstetric providers and midwives. That's about 60% of our utilization. We also get some utilization from family medicine, primary care providers. We are getting increasing amount of calls from substance use disorder providers. We had a substance use disorder initiative. We had some increase in our funding. We now engage actually the SUD community. We get calls from them, both to help them provide better psychiatric care, more higher quality psychiatric care for pregnant and postpartum women. And then also we help frontline OB providers, be prescribing MOUD and so forth. About 15% of our calls, a little bit less than 15, come from psychiatric providers. You may be familiar with, a lot of psychiatrists don't feel comfortable treating pregnant and postpartum women. So we really need to help our psychiatric colleagues feel comfortable providing care to those that need it. Then about 5% of our calls come from pediatric providers. We have seen this increase during the pandemic, largely because they're seeing it more. We've actually been getting more training requests as well. They're mainly calling during well child visits, or they can call about a teen pregnancy, but most of the calls are during well child visits. They're calling the baby's provider and they call after if mom's screened positive. And we also have a toolkit for pediatric providers as well, and also for SUD providers. We have an SUD toolkit as well. Next slide, please. And all of that's available on our website. So next is resource and referral. So I've talked a lot about what we do in regards to, when people have a medication question, and I talked about that, that patient I described, the Perinatal call this morning, she was calling asking also about therapy. So what we do there is we link women with resources, support groups, therapy, and other community resources. And we contract with an organization called William James College Interface. They manage our database. So this database includes therapists throughout the state, psychiatric providers, and it's updated almost daily with any changes in what insurances they take, whether they're available. So when we do these referrals, we're looking into this live database and not giving like a stale list of resources. And we provide many consultations that aren't medication based and are around therapy. And we're always recommending therapy because that's part of the evidence-based treatment and is often first line for more mild illness. Next slide, please. So one of the key things about this is people often think you build it, they will come. Our experience, and as we learn about other programs throughout the country, is their engagement is a really critical component to this. There needs to be a very, very active engagement process throughout building these programs and sustaining them. And so that is also a key part of this. All of these work best in the context of a very proactive engagement plan in which the frontline providers and other stakeholders are engaged throughout the process in a very proactive way. Next slide. So one of the reasons that I think our model has gotten a lot of attention is because it leverages us as psychiatric providers as a limited resource. As I mentioned, never be enough of us to see the patients that need one. And our program is staffed. All of the patients in Massachusetts have access to psychiatric care. The pregnant and postpartum women have access to psychiatric care through their frontline providers because any of them can call us and we can help hold their hand to help them manage the patient. And our program is staffed with one full-time equivalent of perinatal psychiatrists. That's split between 5 psychiatrists throughout the state. And we have 2.5 full-time equivalents of resource and referral specialists. We have 3 hubs. One is at Brigham and Women's Hospital in the eastern part of the state. One is at UMass Medical School where I am. And then we have one at Bay State Health in the western part of the state. So when our 855 number rings, it may go to any of these hubs. They take the call. I'm on call today, for example, they page me and I will return the provider's call. If it was another day, it might go to our psychiatrist at Brigham. And then when we were doing more consults in person, we would be doing those consultations at any of those hubs. Now with telepsychiatry, this is much more fluid and we can really provide them anywhere throughout the state, which has been really nice. And we see. So since our launch, we launched in 2014, we've served many providers and parents. We have enrolled 159 practices, which is 76% of the practices in the state. And this covers over 80% of the deliveries. Any of the practices can call us. We have enrolled 76%. And of the enrolled practices, 64% or 110 of them are actively utilizing us. So that's we're quite excited about that because the majority of them are calling us after we enroll them. And as far as how many individuals women and other perinatal individuals we've served almost 9,000 women. And you think about this is over 6 years and we serve about 200 to 300 women per month. And this is with one full-time equivalent of a psychiatrist, right? There's no way myself could ever see that many women on my own, or split between all of us if we didn't have this model. And then as far as the telephone encounters, so of the, almost 9,000 women we served, the majority of them do have that provider to provider telephone encounter. Like the example I gave this morning about the provider who called asking about sertraline. About 10 to, it fluctuates between 10 and 20% of those telephone encounters or telephone consultations turn into a face-to-face evaluation or face-to-face consultation. Next slide. And part of the reason that this is really important is that we can see people very quickly. So if someone needs a consultation, we can usually get them in within a week or 2. So that's very quick, right? It is unheard of to get to see a perinatal psychiatrist within a week or 2. And so that's one of the reasons that I think this is really important because what we do is the vast majority, we do a telephone consultation. And then in a much smaller number, we do those one-time consults. So that's how it leverages us as a limited resource. And then as you can see, many times we're doing referrals for therapy. So we've done over 10,000 referrals for psychotherapy. And then the 31 number there is that of the face-to-face evaluations we've seen, 31 of them now have been done through telepsychiatry because since COVID, we've been doing many more of these, which actually really helps with our show rate and has actually been we were doing a little bit of telepsychiatry before, but now we're almost all telepsychiatry, which has been for us a good progress. Next slide. So this is just presenting our data in a different way. The red bars are the practices that we have enrolled, and the blue line is the number of patients we've served. So as you can see in the beginning, we were really, as we enrolled practices, the number of patients were going up. Now the number of practices we enrolled has plateaued, but we continue, our volume for individuals that we serve continues to go up. Next slide. So when we think about the progression of this program throughout, since it was created in, it started in 2014, we began to create it in 2016. We were really initially focused on depression, and that was quite purposeful. We did not want to go into practices and overwhelm them with, we want you to address depression, anxiety, SUDs, and everything. It was quite new at the time. It was a huge culture shift. So we were very specific to depression. We started expanding to depression, anxiety. Around that time, a lot of these recommendations came out, which made that much more palatable. We noticed and we found and started actively working with them around addressing bipolar disorder. We recommend they screen for bipolar disorder, and we have found that they're often calling us about this, screening for, and even starting meds. Would it be better if all these patients with bipolar disorder had a psychiatrist? Absolutely. But often there's a wait. So it's better that we can help them at least start medicines, start medication treatment while waiting for a psychiatrist, so they're not waiting months. Because in Massachusetts, it can be up to 6 months, especially with public health insurance, for a psychiatrist. And when someone's pregnant, that's really not good enough. So we can help them manage. And we're amazed at how the providers how their comfort level with prescribing pretty complicated regimens has gone up. It's been really, honestly, beyond what I ever would have expected. As I mentioned, in 2018, we had a substance use disorder expansion and are actively working with stakeholders in the SUD world and also engaging SUD practices and helping OBs address substance use disorders. And then what we've been focused on last year and this year is obviously we're responding to COVID-19 and making changes around that, and also health equity. We have had, this is the biggest initiative we have right now. We're really looking at all of everything we're doing in our program with a health equity lens and looking at what do we need to change and what do we need to do to make sure that all of the patients all the practices that serve underserved populations are engaged, and also that as we provide our consultation, we put out trainings and resources, that these are all done in a way that we are elevating the care so that we're practicing in that way, and we're teaching others to practice with a health equity lens, and it's in a culturally responsive way and with cultural humility. Next slide. And I'm happy to answer more questions about that. So this is a little bit more detail, which I started alluding to. So we are internally working on shifting our culture to address racism and promoting equity and belonging internally. We're explicitly asking about questions during our consultative services. We're integrating it, for example, into our templates for our consultations. We're also integrating content into our trainings and products. We're looking at the language that we're using to making sure that we're using bias-free, non-stigmatizing language. We're also expanding our resources to include resources specifically for women of color and other underserved communities. We're also implementing program measures. We actually right now do not ask the race or ethnicity of the women that we serve. We're not talking to the women directly. If we aren't measuring it, we can't improve the quality of care we're providing. And so that is something that we are actively in the process of adding this to our database and to our internal processes so we can be asking about this. There's a ton of opportunity here, and there's a lot of work to be done. This is a kind of high level summary of some of our initiatives and goals. Next slide. So to put this in context, untreated perinatal mood and anxiety disorders come at a very high cost. They're estimated to cost $32,000 per mother and child diet per year. If you take the state of Massachusetts, where we have approximately 72,000 births each year, and you consider that less than a quarter of them are going to get treatment without a system in place, that results in over $345 million per year in cost. Next slide. Our program costs $13.89 per woman per year, or just over $1 a month. Our total budget is approximately $1 million per year. So it's much less expensive to address perinatal mental health and substance use disorders than to let it go unaddressed. Next slide. And one of the things we're really excited about is that our costs are recuperated through a legislated surcharge. So in 2015, the state passed legislation. This was done both with advocacy combined with the Child Access Program and the Perinatal Access Program, that 50% of it is recuperated through the insurer. So the way this works is that are a program, the total budget for both programs is 3.8 million, and half of that is recuperated through the insurers because it's a surcharge that the insurance companies have, the private plans have to pay that is proportional to their amount of patients that are served each year. And they pay that surcharge each year. So it makes our program much more sustainable. Next slide. So in summary, with MCPAP for Moms, all women across Massachusetts have access to evidence-based treatment for mental health and substance disorders because any of their providers can call us. Next slide. And we're excited that it inspired Congresswoman Catherine Clark to put forth the 21st century, the bringing postpartum depression out of the shadows Act, which then got folded into the 21st Century Cures Act and has led to HRSA funding that got appropriated, that now there's 7 states who have HRSA funding for these programs. So it's serving as a model for other states, can serve as a model for Texas. And, you know, we're very excited about that. Next slide. And there's now 15 programs available throughout the country. It'd be great if we can add Texas to the slide soon. These are different programs. Next slide. And they're all funded in different ways. So most of them have these 3 core components. And what we find though is they need to be tailored for each state or healthcare system. So if we think about Texas, Texas has far more births than Massachusetts, or in fact, most states throughout the country. So obviously for your state, there would have to be a lot of tailoring given the wide geographic region that you're covering and also the amount of births. But in general, they tend to have these 3 core components: training and toolkits, resource and referral, and consultation. Next slide. And just this gives an example of, like, you know, so for example, Washington has it has training and toolkits and consultation, as does Wisconsin. The more robust programs have resource and referral. We have that in Massachusetts. When people have less funding, they tend not to put this in. Our experience has been that this is really helpful, the resource and referral, especially in the beginning, because in the beginning, they don't necessarily want to do this themselves. So they call for seeking a therapy referral, and then we can engage them in the process of, well, let's think about if they do need meds, you know, engaging the OB in that process and engaging them and assessing them further and following up with the patient and so forth. So, but it can be done without that too. So this can be implemented various ways. Next slide. And again, this is done in the context of their legislation, their funding. They may have complementary programs, all these other pieces. They're involved in that tailoring process. Next slide. And, you know, as you're all aware, because you are a group of stakeholders that are all together here, and obviously well organized and led, that engaging multi-level stakeholders when you're implementing and developing one of these and getting funding is really critical. So the pediatric access program, and certainly Massachusetts, and we've seen this throughout the rest of the country, is really critical. Community partners and advocates, your Department of Public Health or DMH and Massachusetts is separate, the legislature, and engaging all these folks. And then the internal team, you know, you have perinatal psychiatrists, there's usually a leadership team. We have our resource and referral specialists, and we also work with obstetrical liaisons. I mentioned that engagement process. Having someone in their club really, really helps, because I'm a physician, but I don't deliver babies. So I'm not totally in their club. And having someone in their club to help grease the wheels for that engagement and help us understand how to engage that community and understand their culture, we found really, really helpful throughout this process. Next slide. And next slide. And just to note that we have a network of maternal and child access programs. This is funded through the Perinatal Fund. The goal of this network is to have peer learning and sharing of resources across the country for these different access programs that are developing. And the other goal is program evaluation. So we currently have a grant funded through PCORI, which I'm DPI on that grant. And what we're doing there is we're actually doing a comparative effectiveness study on the program components of access programs. So what we do is this is free, funded through the Perinatal Fund, and it's a nice community. Any of you are welcome to join. We have a track for, you know, we talk a lot about advocacy, and we talk a lot about programs that are aspiring to have an access program and helping with that piece. So it's not just for established or funded programs. So I think several of you are already members, but if any of you are interested, you can email me and you're welcome to join. Next slide. So in summary, you know, we do believe, and we've certainly found this through MCPAP for Moms, that increasing frontline provider capacity to address perinatal depression can promote maternal and child health, and that, you know, these access programs help leverage this limited resource. And we're amazed at how much the culture shifts when people have a lifeline to call and they have someone to hold their hand and help them do this work. The culture certainly shifted in Massachusetts. And the good news is that among professional societies and other governmental organizations, the standards are changing. And so really the goal of these programs is not to sort of like help them become psychiatrists, because that's not the goal. That would never work. The goal is to help them, meet these changing standards of care, which are hard for them to do because they haven't necessarily been trained in this, nor do they have the resources. So, and we've certainly seen it shift a lot in Massachusetts, and we're excited that it's happening in the rest of the country. And hopefully you'll have one in Texas soon. So I'm happy to answer questions, and thank you for your time. I think we have a few minutes for questions.
Absolutely, and thank you, Dr. Byatt, again for helping us here in the state of Texas, and for transparency. We had her do the same type of presentation to our Perinatal Quality Improvement Collaborative for the state of Texas. It's called the Texas Collaborative for Healthy Mothers and Babies. And again, I think there was a lot of excitement there during that conversation. If you have a question, please raise your hand. I know Dr. Nemiroff has a question. Let me start off with him.
Dr. Byatt, thank you so much for a very informative presentation. So
You're
most
welcome.
you and the rest of the group that we recruited Jeffrey Newport to run our perinatal psychiatry program here at Dell Medical School. This was a joint recruitment of the Institute of Early Life Adversity and the Department of OBGYN and Psychiatry. He's been a national leader in perinatal psychiatry. He's on this call. I'm going to introduce you to him in a minute, but I'll just point out in the last issue of the American Journal of Psychiatry, he was the senior author of a critical article on the role of antidepressant on the risk for autism and autism spectrum disorder. Our program is booming, but let me just ask Jeff to say hello and weigh in a little. Jeffrey?
Yeah, thank you, Charlie, and Nancy. I hope it's okay if I call you, if I'm familiar enough to call you Nancy.
Yeah, of course.
Certainly, with regard to me, you were preaching to the choir. And
oh, I know I was, and I know you. Yeah, of course.
Yeah,
Call me Nancy. I know we know each other.
It was wonderful to hear you lay all of that out. For the group, I'll let you know that the news is good in that a lot of the components that Nancy was describing is you can definitely see parallels with what she was describing with regard to CPAN and TCHAP. Certainly a lot of parallels there, and a lot of those components exist in the state of Texas, albeit in a haphazard, often disjointed manner. But there's a lot of talent and awareness in the state with regard to that. So for example, in terms of referral networks, is the Pregnancy and Postpartum Health Alliance of Texas. When I arrived in Florida some years ago, there was nothing like that. And as Charlie can tell you, it took me several years to scratch and claw out a strong referral base. And I've been in Austin just a little over a year, and have already been able to do that just very quickly, so that the growth of our program at Dell, our perinatal program at Dell, is about a year ahead of schedule. And so there are those networks that are available for referral. In terms of consultation services, I'm actually a consultant for Postpartum Support International. I haven't gotten any calls from anyone in Texas yet, and we do precisely the type of provider-to-provider consultation that Nancy was describing through the Postpartum Support Consult Service, and what you guys are familiar with doing with CPAN. And I can tell you it works every bit as well there as it does for child and adolescent mental health. So there's a lot to like in terms of component pieces being there and having an overarching structure like the Texas Child Mental Health Care Consortium, coordinating all of these various efforts in perinatal psychiatry. I think things could move very, very quickly. And as Nancy said, we're a big state, not just population wise, but but area-wise, and there's people in these remote areas. I can promise you there are obstetricians in rural counties in Texas who are managing bipolar disorder in pregnancy in the postpartum period, and just out of necessity because
You're right, and that's what. Yep.
They don't have good people close.
And we have a lot of psychiatrists in Massachusetts, more than a lot of places.
Yeah.
Yeah. So it must, and I imagine, yeah. Jeff, I didn't realize that. I knew you'd recruited. You knew you left Texas because we consult with Florida on their access program, and everyone was very disappointed you'd left Florida. But I'm missing you because of the, obviously really important resources you were providing down there. I hadn't realized that you recruited to Texas for this reason. That's great. That's very exciting.
Charlie made me an offer I couldn't refuse.
Yeah, no, I could. That's great. I didn't know the context.
So we have several other hands, people that are trying to jump in. So let me start with Dr. Plitzka, then Dr. Trivedi, Dr. Vo, and then Dr. Williams. But so Dr. Plitzka? Oh, you're on mute, sir.
I wonder if you could say just a little bit more about that referral hub when people need therapy. Does that entity, do they kind of take responsibility at that point and say, we'll find them a therapist? And do they just find therapists, or do they also seek out long-term psychiatric care as well?
Yeah, that's a great question. So they do seek out long-term psychiatric care. That's the trickier part. The therapy, we can typically get people in relatively quickly. I mean, it gets more complicated in certain circumstances, but for the most part, we can get people into therapy relatively quickly. The challenging part is psychiatric providers, especially those that are comfortable treating pregnant and postpartum women. So that's when we're often doing this, what we call bridge treatment, where we do a one-time consult. And we, as Jeff was also saying, we help the frontline provider provide care until they can get in. But the goal is certainly, and what we find is effective. We commiserate with the provider, like, yes, they need a psychiatrist. Absolutely, you should not be managing bipolar disorder. We get it. But are you okay kind of starting the med off? We'll do the consultation. We'll discuss the risks and benefits after, and we'll call you, and you can call us back with questions. And we do that. What we're seeing during COVID is that we're doing now some more follow-ups, because I've done them one last week and I have one today, because what we're finding is it's harder to find a psychiatrist. And so now these OBs, or in sometimes primary care, are managing women with bipolar disorder. And like, there's a patient that started on lamotrigine, and now the provider's like, I don't know what to do because she's still symptomatic. And so now we're doing some follow-ups, which is new for us, because, and she specifically said it's because during COVID, like she's having trouble. So we're doing actually more of that now, which isn't ideal, but it's better than, not having the care, right? But our goal is certainly to get them a long-term psychiatrist, and we do that, but it's challenging.
In terms of the therapist, these folks have a contract, and presumably they have a roster of who's taking patients, and they can plug them in. You're not having to go back. They're not calling you back and say, sorry, we can't find anybody. It's back in your court, or how, in other words, how does the back and forth work with that entity?
So we have a couple ways that we do it. If it's a non-provide, if it's a like a nurse or somebody else in the practice, they can just call and ask for a list for the patient. Then we give them a list where we match it with insurance, what insurance they take, whether the therapist is taking patients. We give them a list, and then they give it to the patient. The other thing we do is we call the patients and help refer them for therapy. In that case, we stick with the patient. We never go back to the provider and say, sorry, we can't help you out. Like, it's your, we never do that. Because that probably wouldn't make them very happy, but it can be hard. So we may give an update, and sometimes I think that's probably one of the, sometimes it's hard, but for the most part, we can get people into therapy pretty quickly, but we continue to work with them until we get them in. And then we try to offer, if there is a longer wait, we offer other resources, like, other things that they can do that other than a therapy, other supports and so forth. Does that answer your question?
But it sounds like you're doing the work. I got the impression that William James outfit, that they took that task away from you.
Yes, no, thank you. Thank you for clarifying the question. So we do that ourselves. They created our database. They update the database. So we contract with them every year. They maintain the database. They update the database. But once we basically pay for that database each year. And then, but our resource and referral specialists do the search and call the women. So they're fully employed by McPat for Moms. And then we contract with William James College Interface to manage the database and populate the database. Does that make sense?
Yeah, that's clear.
Yeah.
All right, thanks.
Dr. Trivedi.
So thank you very much for your presentation and congratulations for the success, because like all good ideas, having developed a lot of these networks, a lot of good ideas are really, there is a big need, and like OBs wanted, the real thing is they get paralyzed about what to do. So you're providing that, and all your explanation about the system and the stakeholders and all important and essential, but maybe you didn't speak much about something that I think has to be a key. And so I'd like to hear your thoughts about it. And that is the leadership and the doggedness that the champion, it sounds like you, but has to provide. That is more, even people don't describe that well or extensively, but I have to imagine, based on my experiences, that is what you got to do.
Yeah,
Can
you do.
More to that, and because that would be something similar to model here if we do this.
That's a great point. Yeah. Go ahead. Were you finished with the question? I don't know if I interrupted you.
So say something more about how you went about it, what you were.
Yeah. Yeah, no, I don't think to mention that because it felt like such a team effort. But you're right. I mean, and actually someone said to me the other day, because as we see these access programs be implemented throughout the country, it is, I mean, for me, this was like my K award, right? K award, for those who don't know, my career development award, my grant, my K award was to basically pilot MCPAP for moms. And a few months later, we got statewide funding and I had to pivot my K, which was a great problem to have, right? So I was like super committed to this and it was really my baby. So I spent an extraordinary amount of time and effort engaging practices, working with Mass ACOG, working with my dear colleague, Tiffany Moore-Simas, who's really been my OB partner throughout the process. Because it's kind of like, if you think about playgrounds, you're kind of like playing in someone else's playground. You don't just go over there and go to someone's backyard and start playing in their playground. You have to actually make friends with them. You have to build a relationship and play in the playground together. Otherwise, they're gonna look out the window and be like, what are you doing in my playground? So that whole process of like developing the relationships you can play in on the playground together, or like on their play set, swing set, whatever, it really does take a lot of time and effort. And I think also there's a point where I do think a lot of the success about this is all about relationships. I think that's very true. So I really appreciate you raising that. And I think one of the things that we did was we just went out, we met with people in person, we developed relationship with Mass ACOG, the Postpartum Depression Commission, and also just any sort of stakeholder who's working with pregnant and postpartum women, but a lot of it is about relationships and getting out there and giving the talks and engaging people. And so you're right, that is a bit, and as we see the challenge with access programs is that when there's like a super busy, person leading it that doesn't necessarily have the time or maybe doesn't have the dedication to doing that, it's a lot harder because it's not you will build it, they will come. You have to like engage them in coming. And there's a piece with this where I think, where it's hard to do it because it does help if it's provider to provider, that engagement process. You can have other people do it, but there is an element where OBs want to hear from other physicians. So it's hard, it's not that engagement, it's hard to delegate that to someone that's sort of doesn't prescribe meds, for example, or doesn't get what it's like to use the EMR that we all are frustrated by or what have you. So that's another component where I think sometimes people think, oh, well, like, and there's obviously it's a big team and everyone's role is critical. That engagement, there does have to be a fair amount of commitment from someone who's a psychiatrist, I think, or some sort of prescribing provider, because that's what the OBs, that's who they want to hear from. That's just the reality. So it's a good question.
Thanks a lot.
Let's go to Dr. Vo, Alex Vo.
Hey, thank you for the wonderful presentation. I just have a quick question that relates to what Steve just asked in terms of the referral. Since you have a program now that's been running for about 6 years, do you have any rate or data on rate of patients actually enacting and following through on the referrals that you recommend? And then how do you actually put in place mechanism to track that if you do? So
it's a great question. And it's a big challenge because, so what we're actually doing a study, I have an RCT funded, I'm the PI of an RCT, what we're actually measuring exactly that. What we're doing is we're looking at, it's a cluster RCT, so randomizing by practice, and we're looking at MCPAP for moms versus this other intervention that's basically MCPAP for moms with a components of collaborative care on top of it. So we're measuring that in that study among these practices throughout Massachusetts. I think the way you would have to do that to measure the treatment participation is you would have to have the resource and referral specialist call patients up and follow up. We do call them 1 month later and we triage, and if they haven't engaged, we help them at that point. We have not, from a, we do not necessarily systematically record that data. Part of it's because it hasn't been a priority. When I first, being a researcher, when we first proposed this, I had all sorts of I wanted to include that. The state really didn't want to fund it. So it's interesting, but I have gotten research funds to be able to look at some of these things, but to implement that as part of the program, we have actually found to be quite challenging, because to call them up and ask all those questions is sort of another component that for ours, the funding is really for the clinical program, and there's been a hard line where they have not wanted to fund that kind of stuff. And I think the other piece of it is that you could argue that, they only call us about the people that they're having the most challenges with, because the thinking with this is that you talk to one person, they do a consultation, but it's helping many, many other people than the ones they call about. So when you're only looking at the people they call, it's a very biased sample. So that's why some people argue that it doesn't mean you shouldn't do it, but that's one kind of argument, because the goal is that you're helping many, many other people because they learn, and then it raises standard of care for the other patients that they treat as well. Does that make sense?
It does, thank you. But, I'm just thinking that you put up a data point up there that says, the problem with postpartum depression and all these other issues, it's a $300 billion or $1 million issue every year for your state. So having follow through with these patients getting the appropriate care actually would contribute to understanding that a little bit better.
Totally.
So,
yeah, and that's why I have gotten that funding through. We're also, the PCOR grant, that's actually what we're looking at too. We're looking at treatment participation in that study. We're using claims data. So I've done it through research dollars, not through the program. I would be happy if there is resources to it to help think about how to do that, because I agree it's a really important thing to do. And I think if a program could be built to have that in there from the very beginning, it would be wonderful. Because I agree with you. I think it's really, really important. And we'll have data on that to come when these studies when we have our results, they're in process still.
Very good. Dr. Williams, Laura Williams.
Yes, I just echo everybody else's comments. A lovely presentation. We've been looking at, obviously we haven't heard you speak yet, but we knew that MCPAP was doing the maternal one. There's definitely a lot of interest in Texas. I know a couple of different providers within our CPAN group, within our larger consortium, that do provide this level of consultation. And so I do think that we have probably a lot of the elements in place. We are planning on tracking a lot of those data elements that you had sort of wished that you'd done from the beginning. We actually have a process where we can even ask the individual in question to rate their symptoms and then track them over time. So it'd be another way where we could actually capture that data. Are they going to the resource, and are they getting better? It's exciting to hear how great your program is, and how much it's helped women and the families that they are seeing. So I'm excited to hear. Hopefully there are some ways that we can do that in Texas.
Thank you.
Thanks, Laurel. Octavio, Dr. Martinez.
Hi, Dr. Bayet. My question, a quick one, is what kind of penetration have you had with really historically marginalized or minority communities, especially obviously women, as also have you seen any indication this is really being useful as well for teenage pregnancy and the issues that come there, along with the mental health and substance use issues?
Yeah, it's a great question. Thank you for asking that. So as far as teen pregnancies, they're not the majority of our calls, but we do get them. We tend to get them from the pediatric providers, and we work with our MCPAP team on those. So if the issue is more around perinatal, we do the face-to-face consultation. For example, if it's more around a child, they do the consultation and we consult with them. So we go, because none of our psychiatrists are child trained. So we consult with them around, we do get calls. It's not the majority of calls, but we do get some. So as I mentioned earlier, in regards to the, whether we're serving underserved communities and women of color, for example, we don't have that data. So which we are now actively working to do. And part of it, I think when we first developed this program, we were so focused on, we just want to get them to address depression. And we were so focused on just getting them to, because at the time it was a huge culture shift. I wish we had done this from the beginning, hindsight's 2020, but what we're doing now is adding that in because we are getting a lot of utilization, and it's not okay that we don't know. We don't know the race or ethnicity of the women we serve. It's not something we capture. And what we're going to do, we're actually in the process of adding this in now, we'll be adding, when providers call our program, our resource and referral specialists will ask, how does the patient identify as far as race or ethnicity? And then we will include that in our database when they call. So one, the provider's thinking about it, that we're asking, and then when we get it, we'll be thinking about it, and it will, one, help clinical care, and also we'll know who we're serving. So for example, if we find that we know the percentages of different race and ethnicities in the state, and if we find that the general proportion isn't consistent with the proportion of who we're serving, obviously that's a problem, and we have to know that, and we don't right now. So that's something that we're actively working on. I wish I said we've been recording from the beginning, but we haven't. So, but we're working on it.
Sounds good. Sounds like a lesson learned, but
totally.
You can help others, obviously. Thank you.
Yeah, no. So do that from the start. That would be my recommendation there.
Very good. Dr. Wakefield.
Yes, thank you. And thank you, Dr. Byatt, for all you've presented today and all you're doing and all you've taught me over the years. So I am trained and practice both in child psychiatry and perinatal psychiatry. And I feel like that's a very easy flow and something I got interested in because of all the moms I was seeing in clinic with their babies, and also thinking about the sequela to babies when you're treating moms. My question, because we started out as a consortium of child and adolescent psychiatrists, and we're looking at expanding that over time to this perinatal application as well. Do you see benefits of training the child psychiatrist, or you see limitations? Just it prompted me when you were talking about, will we collaborate with our child psychiatry colleagues about the teen pregnancy and things like that? And I definitely have teen moms in my perinatal practice as well. And that is an interesting cross-section. Do you see limitations of training child psychiatrists in perinatal medicine or perinatal psychiatry in this way? Or, I mean, how did you guys train up so many or enough perinatal psychiatrists? I'm thinking of our population and the size of our state.
Yeah, it's a good question. So I think one thing is, I think absolutely child psychiatrists can do, like Kathy Wisner, who I'm sure you all know, she's a child psychiatrist. So I think absolutely child psychiatrists can learn this and do this. I mean, I think especially if they're doing both and treating adults, like for sure. We have not focused on training, because we thought about this. We have not focused on training the MCPAP psychiatrists in perinatal psychiatry. We've done a couple of trainings, but it's so complicated. They don't treat adults. And so it's still adult psychiatry. So because the women we're serving usually are adults. And so what we do is we consult with them and teach on, and same thing for us. None of us are child psychiatrists. So we consult with them over the child psychiatry because it's very different, And so that's what we do, is we consult with each other and teach each other case by case. In regards to your question about, you had another question. There was two questions. What was the other one? It was,
well, I think my biggest question is about how do we train, because there aren't that many perinatal psychiatrists.
Oh, that's right.
And so for such a large state and so much population, when we're looking at who to train, it seems like a natural flow, not that it should be limited to child psychiatrists, but it seems like a natural flow. I was working with the team on different trainings that could be available. Anyway, so just to speak to that of any limitation, and I think you did a little bit already. But.
Yeah, no, thank you for clarifying that, repeating the question, because so I definitely think child psychiatrists. I think the tricky thing is it's just that it's adult psychiatry, right? That's the tricky thing. But I do think they could, I do think the flow is there. And I think, I think it makes a lot of sense in many ways. I think part of why we didn't do that in Massachusetts is because we have a lot of perinatal psychiatrists in Massachusetts. Like, we are a unique state. We're like dripping, but even though we still don't have enough access, but we have a lot of academic medical centers. We have a lot of perinatal psychiatrists. We have a fellowship, we just have a lot here. And so I think we're in a unique position where it's not hard for us to find a perinatal psychiatrist, but there's a lot of states where it is. And it is good to have more than one. It's good to have a few. You already have two right here, which is great, which is better than a lot of states. So I think that it's a balance. But I think there's no reason that I think child psychiatrists would be someone you could certainly train, just with the knowledge that, they are practicing with perinatal psychiatry is adult psychiatry, so they kind of have to know that piece. But I think in general, I always think with these things, you don't want perfect, the enemy of the good. And when someone's calling, even our psychiatrists, when we started doing SUD expansion, they were a little nervous. They'd be like, but we're not SUD specialists. We're like, we're going to know way more than the person calling. And we're all comfortable now and we all do it. But in the beginning, people were really anxious about it. So I think everyone, especially actually psychiatrists, get anxious about perinatal psychiatry because we all want to do the right thing by the baby, right? But I think if you train people, I think the key thing to remember here, and I think this is key to these programs and why they're scalable, you don't want perfect, the enemy of the good, and they're going to know way more than the person calling. And part of it's getting comfortable with that, and it's not really about the details. A lot of it's about the principles of how you treat, about how you treat pregnant and postpartum women, and that's often what people remember, and that's often the most important piece. And that part is actually not as hard to learn as people may think. Does that answer your question?
It does. Thank you. I think on the scale of Texas with the population and it being so different from Massachusetts with so many very specialized, highly specialized psychiatrists in Massachusetts with a smaller population base, it's just a very different thing about how to get enough people trained where they're comfortable. I am always amazed at how uncomfortable adult psychiatrists are.
Absolutely.
Perinatal psychiatry.
Totally.
So we're going
to
and just trying to think about the easiest way to do that on this scale.
And there's the national curriculum, Lauren Osborne and Sarah Nagel-Yang have that wonderful national curriculum. So we didn't have that 5 years ago.
Right,
so I think you could train people to do this. Like it's hard, but it's not that hard. And like that national curriculum, it's got hours and hours of things. If they do that, they have a perinatal clinic where they see a lot of pregnant and postpartum women, you can learn this. Yeah. It's, so I definitely think it can be done. I think the national curriculum is also a great resource. And then just practicing seeing patients. I think the most important thing is they feel confident.
Yeah.
Because when they call, the consultations can be a little bit tricky and they need to feel confident, I
wonder if we could facilitate that with an echo model too for some of our psychiatrists who are on the call, and talk about case presentations. And
that's a great idea. Okay. When we first started, we talked every week about our cases. They were all perinatal psychiatrists, but a lot of it was the first time we had a program like this. A lot of it was about how do you manage when an OB calls and they just want you to take the patient and they're like, I don't want to prescribe an SSRI. Like a lot of it was about managing the relationship. It was less the content, but we talked every week. So it was in some ways an echo, but I think our idea of an echo model is great because you could have that be more content based too.
Along those same lines, how much work have you done with your local mental health authorities and the psychiatrists that are based there?
Yeah, it's a great question. So we are funded by the Department of Mental Health in Massachusetts. They are our funder, but it hasn't been a huge focus of what we're doing. We have for example, we did trainings for the Mass Psych Society. I'd say that we're currently talking with the Department of Mental Health around how we can do this better. So for example, we do find that I think one of the things that frustrates us that we still have, that is an ongoing challenge is, for example, when people get referred to like a community mental health center and they're like, it's a 6-month wait for a pregnant person. And then they end up like, we're providing treatment. It's like, can't we prioritize them and like get them on the waiting list because they're pregnant and we have 2 lives involved and so forth. So I think that's something where we do work. We're in the process actually of working with DMH on that and trying to find a way where DMH can, because DMH in our state they have a lot of regulatory power. And so we're actively working with them on that and they fund us. So we have an ongoing collaboration with DMH around that. And also with Department of Public Health in our state, and BSAS, we have separate substance use, mental health and public health in Mass. So we work with all of them.
Very good. Any other questions from the group?
I wanted to ask just one quick question. Nancy, one of the questions I have is what do you guys do with regard to funding challenges, particularly when Medicaid expires? Texas is, there's a lot of about Texas being a high maternal mortality state. And when you look at the breakdown, high on the list of causes are drug overdoses, suicide and homicide, all of which happen later in the postpartum period when funding evaporates. How do you guys navigate those challenges?
Yeah, that's a great question. I think that's a really hard one. There are several of the HRSA funded states don't have Medicaid expansion, so they do find ways to manage it. It's very tricky though, because I mean it's very tricky because they can't get. I mean the problem is like we build the capacity of frontline providers, but the frontline providers they can't even see the frontline providers, right? I mean that's the tricky part. So I think what some states have done is like found ways to work with. To find ways to create some sort of safety net for them. It's that is very, very challenging though. I wish I could give you an easy solution for it, but there are several states that are doing this and they're finding ways around it. But a lot of it's like finding some sort of safety net and finding other options, but it's not ideal. It's a huge challenge.
Yeah, so for those of you who may not be aware of this, in Texas, pregnant women are covered by Medicaid. As soon as they deliver, many of them lose their coverage.
Yeah.
And then secondly, many of us serve individuals that aren't US citizens, and of course they're not eligible either. And so this is a real problem in our state, those two forces.
Right. So I think what a lot of the states do is they work with people who are providing basically free care, and then they consult with them and they try to funnel them to those, because there are health centers and so forth doing that. So I think that's my understanding is that's a lot of what them are doing, but it's a huge challenge. It's a great question. I wish I had an easy solution for that one, but.
All right. Well, Nancy, Dr. Byatt, it really has been a privilege for us to have you here today. Again, thank you. Thank you.
You're
for
welcome.
the times that we've brought you in. Obviously, a lot of interest related to your work and how we can bring that here to the state of Texas. Again, for the group, this is just the beginning of that conversation. The legislature will need to weigh in if they want to direct us in this path. But I think all of us will be very interested in the work that you're doing and what it would take for us to do so. Obviously, a lot of success in what you're doing right now. So thank you.
Yeah, you're welcome. Thank you for having me. And I hope that I hope you convince the legislature that this is important. This is the direction they want to go. Yeah. So it's been a pleasure. All right. Bye. Thank you.
Look forward to continued conversations.
Yes, very much so. Me too. Okay.
Right.
Bye-bye.
Bye. All right. Dr. Nemroff sent me a quick email just a little bit ago about some updates on the research and IRB approval. Charlie, you want to tell folks what you learned?
Yeah, fundamentally, we just received an email from UT Southwestern, obviously probably spurred by Carol, that the trauma network will be approved today. So we're ready to launch.
Very good. All right.
Congratulations.
With that good news, why don't we take a quick lunch break, and I think we can go to about 12:20 and then start. So it's just a little short of 30 minutes, especially since we're all mostly in our own homes. I think we can be quick. And let's start back at 12:20, and we'll be jumping into the finance, or actually to cost and the finance conversation. So I'll see everyone in about 20 minutes. Thank you. we're going to start in right around 3 minutes. And so please finish up what you're doing. And at 12:20, we will resume the consortium's work. Thank you. We're going to start in 1 minute. So please finish up what you're doing and get ready to rejoin the conversation. Thanks. All right, I think we're ready to go. I was just counting the executive members that are on our participant list, and it looks like we're still at quorum. So I think we're good to continue the conversation. What we're going to do next is get an update on the centralized operating support hub. And after that conversation, we're going to talk about the budget and unused funds and how we're trying to address those needs. So with that, Laurel, let me go ahead and hand off to you and look forward to the update. Thanks. Laurel, you're still muted.
Yeah, I have to unmute in 2 different places. Can you hear me now?
You're good now. Thanks.
Okay. So welcome. Hello, everybody. Hope you had a nice weekend and just hopefully everybody did okay. Your families are okay from the storm. I know it missed us, largely, but there's still people out there that got hit pretty bad. So we are going to update you. The first thing we were going to do was actually show you the work to date for the actual data management system that we're using with our vendor trait. They are actually going to be joining the call and sharing their screen. And I don't see them on yet, so that's what I've been sort of furiously texting about behind the scenes. So I can probably, Jennifer, can you text Malachi and see if she's having any trouble getting on, so I can maybe just keep moving forward and stop when she's available. So we did actually take lessons learned from other state CPAN programs as far as data, what data we wanted to collect. We actually are collecting, if the PCP is willing to provide it, we are collecting race, age, and gender, as the PCP knows that of the patient that they're calling on. So we will have that level of information. We are on target for the vendor. They have done the first 2 phases of the build out for CPAN, which was first the enrollment piece to get PCPs to be enrolled. So that piece has been live. All the training for all the HRIs has occurred for how to do the enrollment through the platform. And they will be moving to a system where a PCP could enroll without even our team touching them first. So we'll have a rollout for that in the near future. They have also completed the call form. And as discussed, there's a lot of data elements in that call form that you're going to be seeing in the next few minutes. And so that's the training for how for each of the teams to use the call form is going on right now in the next 2 weeks. And so by the end of these next 2 weeks, all of the CPAN teams will have been trained on part 1 and 2, which both the enrollment as well as how to use of the form. And as soon as the team is trained, they can start using both aspects of it. And then the trait team will be doing the final build out for CPAN, which is actually the position of the PCP doing scales with the families as needed. So again, all the same scales that we're using for TChat, we're going to also be using in CPAN. So if we have a case where a young person has potential ADHD, for example, and the PCP would like to use a scale that we have, our team could help push that out. And again, the family will see it coming from their PCP. They won't see it coming from CPAN. So, but after the scale is done, both the PCP provider and our team at CPAN could see the results so that we could help improve our consultation to the PCP who's providing that care. So I see Malachi was on both as April. So hi, April.
I don't know why. Hi, everyone. I don't know why it's showing up as April because April also is on the call. I'm not sure why.
So in any event, there's a lot of efforts and work that have gone into this build, and we wanted to show the state and the executive committee the work. So I'm actually going to now stop talking. And I've already told them about enrollment and all the HR teams getting their stuff done. So I think mostly what you can do, Malachi, is just kind of share your screen and then show them the product.
Okay. Hi, everyone. I am Malike Amini. I'm the founder and CEO of Trade. Somehow I'm showing up as April here, but I'm not sure why. April is also on the call. So just to get us started, I am going to show just a quick overview of what we're going to cover today. So as I mentioned, I am founder and CEO in Malike, and my colleague April Hishinuma, who is the Director of Research, is also on the call. You've probably met us in the previous meetings already. Just to give you a quick overview, these are things that will actually matter during the demo. So I just wanted to clarify a few things before we launch the actual product demo. As you know, and we have been working on, CPAN has defined some specific roles for each of the, for an HRI, basically, the team at an HRI who's going to be engaging with PCPs. I'm not going to go over all of that detail, but that you can see on the left column, there are some specific roles. Each of those roles has certain functionalities that they have access to. And also, they also have permissions in terms of what they can see or edit if there's any PHI shared on any of the calls. But as we go through this training, you will see some of those nuances and how each role interacts, both in terms of the enrollment processes and also in terms of completing a call session. what we're going to review today then is going to be the staff directory, where you basically, it's user management within the HRI, the clinic directory. So how do you really enroll a clinic and all of their teams, or have them do self-enrollment? We look at the PCP directory, which is enrolling a PCP. Primarily this happens when a PCP calls into CPAN for consultation and they haven't registered. So we'll do the PCP enrollment, the individual PCP enrollment during the call process, so we can demonstrate how the directories and the call forms interact with each other. Next, we will look at the call forms themselves. So this is the consultation form. The part one of the call form will be the referral consultation, identifying the PCP. Is this about a patient? What is the purpose for the call? And then decide what to do next. Who do I transfer this call to? And then the second part of the call form is the behavioral consultation, where you take down basically the health profile of the patient in question, if this is about a patient, and then make some recommendations in terms of diagnosis, medications, additional diagnostics, and also decide what are the next steps in terms of any referrals. So that's kind of the general overview. Are there any questions about kind of the roles or the forms that we need to go over before we launch the demo? Okay, great. So with that, I am going to start the demo. So April and I have kind of developed a script where we're going to interact with each other so that you can actually see how each role, either within a PCP clinic or within the HRI, interacts with everything else that's in the portal. So I am going to now launch into the portal itself. So as you can see, this is where I would end up. I am right now an administrative member of the team, the HRI team, and I'm also a psychiatrist. So I'm going to log in. As you can see, now that we're collecting potential PHI information, the two-factor authentication has been implemented. So now I need to actually put in the code that I just received. And you can see that it logs me in. So it's the username password is no longer sufficient. So now that just because I am a psychiatrist, my default landing place is going to be on the consultation tab of the form. But as an administrator, if somebody's logging in as just a pure admin, you would end up on the staff directory. So I'm going to be on the staff directory. Some of this, I'm going to enroll one staff member just to show how the enrollment works and how the user management works, but then we'll move forward to the other kind of the main pieces of the portal. So here I can obviously search a staff member, but I'm not going to do that. So I'm going to now enroll Jennifer Evans as a member of the team. I'm going to add some phone number for her, and I'm going to make April be the staff member, be Jennifer for now. And I'm going to make this individual a psychiatrist and maybe again an administrative member, because this provides additional features, additional functionalities for Jennifer. So I'm going to save here. Now, if I look for Evans, Jennifer Evans that I just enrolled will show up pending activation. So an email has been sent to her to activate her account. I can resend the email in case she hasn't received it or I have a typo. I can edit everything here and resend. And if she doesn't respond to this activation request, after 30 days, she's going to be considered expired activation, basically, and we need to resend the link again. But April, maybe on your side, you can talk about what's going on, and then we'll look at the status again.
Great. So on my side, I just received an email from Trait. It says that I have to set up my Trait CPAN account. So I'm given a temporary password. I'm going to start my enrollment. copy pasting my username as well as my password. Once I do that, I am prompted to set up my SMS, so which is the two-factor authentication. So I enter my phone number, and I am going to receive a verification code on my phone. Once I enter that verification code, I set up my new password. And now I'm able to log into my own portal, and it should say active on your side, Malika, after you refresh.
Okay, so I'm going to refresh my page and then look for Jennifer. And as you can see, Jennifer activated her account and now she is an active member of the HRI staff. Now, let's say there is a resource coordinator that didn't show up today. And as an admin, I want to actually give Jennifer the option to also be the resource coordinator and provide referrals, because as a psychiatrist, she doesn't have that role. As an admin, she doesn't have that role either. So I go here where I actually created her account and I add her as a resource coordinator as well. What you can see here is I can also change the status of her account. I can deactivate her. Let's say she's going on a leave of absence or she's leaving the hospital altogether. I can delete her account. It doesn't delete her from our database, but it will delete her from the dashboard of the HRI so that it, it keeps it up to date. So I'm going to save this. Now, if I, again, refresh my page, and no, you don't have to refresh your page all the time. I'm doing that because we're doing this too quickly. So now you can see that I added Jennifer's role as administrator, psychiatrist, and a resource coordinator. So this is how a role gets updated for the staff members. Any questions about this? The staff enrollment is probably really simple. Great. So from here, I'm going to go to clinic enrollment. Now, there are various different statuses, as you can see, for clinics. It could be an expired invitation, similar to what we had with the staff members, active clinics, declined clinics, someone who decided not to join altogether, and then other types of, each one indicates a call to action for the person who is the administrator or who's managing enrollments of clinics. Right now, I'm going to register a brand new clinic, and I'm going to call it the, let me just see, Bucks Clinic is not found. So I'm going to add new. I'm going to call it Bucks Pediatrics. Now, what you can see here is that there is a branch and a parent organization. So if I am, let's say, a TCP or some large pediatric organization with multiple locations, what I can do is to add my branch. So say I'm in Houston and add Bucks Pediatrics as a parent organization and then call this a pediatric clinic. What I've done here is I have created individual clinics for ease of use. So a single administrator for each of the branches is going to be managing that branch. But what it does mean is that I have clinicians who go across maybe some of these branches. So the same physician with the same email address, same identity is going to multiple locations. And if there is a patient information that's shared, the parent organization MRNs for all of those patients are unique patients because it's sharing an EMR. So that's what this basically means, meaning that I can share PHI with anyone from Bucks Pediatrics parent organization because it's considered one big, institution with multiple locations. So for this case, I'm going to use Bucks Pediatrics in Houston as one of the locations for Bucks Pediatrics. I will add the main address to say Main Street. And next. Okay, so here you can see that I just created the structure of a clinic. I enrolled effectively a clinic. And it's telling me, how do you want to register the clinic? I have the option to send an email invite or to enroll the clinic myself as an HRI admin. In this particular demo, I'm going to send an email invite to April, and April will be the PCP clinic's admin and does the self-enrollment. And the reason why I'm doing this is to show the interaction between the PCP clinic portal and the HRI portal. But the pages that April is going to see and the enrollment process she's going to go through is exactly what you will see as an HRI admin if you were doing the enrollment on your side. So I'm going to send an email to April now. So I sent an invite to April to enroll her clinic and if I search here, Bucks Pediatrics just created a structure for it, and it's pending the activation of the individual that I sent an email to so that she can sign the agreement and she can enroll the entire clinic on her own. But again, the pages will look exactly the same as if you were registering the clinic yourself. So April, I'm going to stop sharing. And then you should start sharing. You're on mute. I received an email from Trait. It's an invitation to enroll into the CPAN program. Once I open that information, I have a little blurb about what CPAN is and what my role is as a CPAN PCP clinic administrator. I'll be able to enroll my clinic including the PCP providers and staff who will be responsible for the CPAN resources. I will enroll affiliate clinics with different addresses, and I will also update the clinic and PCP information. What is also on this email is the HRI CPAN email, as well as their callback number, so that if they have any questions about CPAN related information, they'll be able to contact their appropriate HRI. So I'm going to click link to create account. I'm prompted to enter my last name, my first name, the email that I want to be contacted by, my phone number, as well as my password. I click create account. I'm prompted to sign the CPAN participation agreement. It is what was provided by the CPAN consortium. It basically has information about what CPAN is as a service, as well as an agreement that I am agreeing to participate into the CPAN program. So once I look at the agreement, I enter my full name as well as my title. At this point, I have the ability to decline or agree. Declining will show up on the HRI side as a declined clinic, but for the purposes of this demo, I'm going to agree. Once I agree, I can see all of my clinic information pre-populated from the HRI side. I can also add my practice main phone number, as well as my practice fax number. The way that this works is that on the left-hand side, it's wizard style. So as I save and continue, I'm able to proceed to the next step. I'm prompted to add any additional sites. I don't have any additional sites within this clinic. My parent organization, as Malika has mentioned, is Bucks Pediatrics. So I'm going to save and continue. I don't have any affiliations, but affiliations would be, for example, accountable care organizations, physician organizations, or other health system affiliations. So I'm going to save and continue. I'm the clinic administrator.
So I can also enter my information. Once I enter my phone number, I can save and continue. The next step is to enter my practice staff. I have two options. I can either add manually or add my practice staff in bulk. I'll go first through the add manually process, and then I will then go into the bulk enrollment. So say that I want to add a physician. I add Alex Lee. Alex Lee. I also enter the phone number for Alex Lee. And I submit. Once I click submit, email is sent to the PCP regarding information about the CPAN program, as well as the option to sign an individual CPAN agreement. Now, let's say that my practice has over 100 PCPs. I would rather, instead of manually uploading each PCP, I want to bulk upload. So I go back to practice staff, where I'm prompted to download a sample spreadsheet, fill out all of my staff, and then upload, review, and verify my staff. So for the purposes of this demonstration, I'm going to assume that I've gathered all the information that Trait has required for uploading staff. And now I'm ready to upload my clinic staff. So I get to choose a file. Great, so our system makes sure that whatever was written in the clinic Excel sheet matches the roles that is given by the CPAN consortium team's role definitions within Trait. So for example, if it says nurse prac, what I meant to say was nurse practitioner. So I'm going to select nurse practitioner. I'm going to save and continue. Trait as an application is able to pick up on errors within the Excel sheet. So if an email field is missing, it'll have a caution symbol. If there's an error in terms of formatting issues, it'll also pick that up and notify it as a red error. And there's also warnings. So if, for example, there were duplicate emails, we would be able to pick that up and make sure that this was not an intentional mistake. And it's a warning that is used to check if a clinic has multiple emails or a clinic just uses one. So I'll go through this process. Also note that in the upper right-hand corner, I'm not allowed to confirm and continue until these warnings are, not the warnings themselves, actually the errors are fixed. So I'm going to select Alex Lee. Alex Lee is missing an email. So I enter an email. Sue has a phone number, red error. It's missing 2 digits. I'm going to save. And now you can see the duplicate emails that are shown in orange. For the purposes of this demo, these duplicate emails are actually on purpose. If a clinic has 1 email, we allow for that within the Trait system. So I'm going to confirm and continue. And as you can see, 13 records have been added successfully during our bulk upload. So once I refresh my homepage, I'm able to see all of the PCPs and office managers that are within my staff in the Trait system. Another thing to note is that once I upload, I will have a clinic status as active. So this indicates on the HRI side that I successfully have enrolled into the CPAN program and I'm ready to use the application. So I'm going to stop sharing my screen and hand the screen sharing over to Malake.
Thanks, April. So I am now
Malachi,
Looks
we
like you
lost you.
froze up. Malachi, it looks like your screen froze up.
April, is it possible for you to continue if Malachi's screen is frozen?
Yes, I can continue. Okay. I will start sharing my screen. Right. So now I'm logging in as an admin and psychiatrist. I'm prompted to show my MFA. So I enter the phone number. Oops. So the clinic that I was just registering, that Malachi was registering, is Bucks Pediatrics in Houston. As an HRI staff, I can now view my clinic and see all the PCPs that are also enrolled. So this is on as an HRI staff. I can see everything the PCP admin has inputted.
Hi, everyone. Sorry, I have no idea what happened. Can you hear me?
Yes.
Okay. Just our internet has been really, really patchy. I'm sorry. Okay. So you showed the clinic status?
Yes. So now I enrolled as an admin and psychiatrist, and I was able to see that my status was active.
Great. So now I'm going to share back my screen. And then add, not this one. Go back to the portal. Okay, so now I'm logged back in. And as you remember, I'm a psychiatrist. Now that we know how the enrollment for the clinics worked, the PCP directory has a list of PCPs and it has a similar format with the provider status and some kind of call to action for the administrator who's responsible for enrollments or follow up on enrollments. But I'm going to show the PCP enrollment through the consultation process. When you enroll an individual PCP, it's typically when a PCP has called in and that individual hasn't registered, so you'll take the information down during the call. You're not reaching out to individual PCPs, you're going after the clinics. So I'm going to start a consultation and we'll see all of the process of PCP enrollment through here. As you can see, again, on the left-hand side, there are some call statuses, consultation statuses. Somebody's awaiting consultation by a psychiatrist. Here you can see that we haven't met the 30-minute timeline in responding back to that call by a psychiatrist, so it actually does show overdue. But you can also see, for example, that there is a callback attempt over the past 3 days by a psychiatrist, and you haven't been able to reach the PCP. The PCP has been unavailable. In that case, if you meet your first call back during the 30 minutes, even if you can't reach the PCP, you've met your 30-minute milestone of responding back to the call. And so it won't show overdue if you try for 6 days and the PCP doesn't respond, as long as you've made your first call attempt during the 30 minutes. So this doesn't show overdue because the PCP is not available. You can also see a task here or a status here that says saved for later. This could happen if you're on the call and let's say the call drops for some reason, or the PCP says, I have to leave, I won't be able to complete this now. Or as a psychiatrist or therapist, I'm so busy during this time that I say, okay, I have all my notes on paper, I'll just put them on the form later. And it has a status of saved for later, and only that same therapist in this case can actually go back and complete that. I didn't do the save for later. So this is somebody else who saved a form for later, and they're going to go back and complete that process on their own because we don't know what happened. And I'll show you during the process where you can actually document this save for later. So I'm going to, and then there are obviously archived, these are completed calls, and we don't put much information on here. We are working on a tab that ends up on this page that says call history. And you can go to the call history, and anything that's been archived and completed is available in much more query-like abilities, so that you can look at the history of an individual call, of an individual patient, or overall do some analytics on that page that shows you kind of what calls took more than, what were the overdue calls, or all kinds of other things are things that you can actually query in the call history tab. So I'm going to start my consultation now, and I am going to enroll one PCP. This is Dr. Adams, and I can see that Dr. Adams has not enrolled. So I'm going to create Dr. Henry Adams. His role is a physician in the PCP clinic, and his phone number is, oops, so you can see my formatting caused an error. And I am going to enroll I'm going to send this email to myself so no one else receives an accidental email from me. And I just created, so as during the call, if a PCP has registered, I basically picked up the call, I clicked, start consultation on my computer. The PCP indicated I'm Dr. Adams. I don't have Dr. Adams, and I just registered the PCP, and that is all you need to enroll a PCP. There's no other process to enrollment, but I will show you some other factors that need to come into the enrollment. You can actually say this is a single practitioner. So if Dr. Adams has Dr. Adams Clinic and no other kind of infrastructure to the PCP clinic, if you click that, then it becomes the entire clinic. So Dr. Adams becomes the medical director and administrator who can complete the process on their own. I'm not going to do that here. I'm going to enroll Dr. Adams in one of the clinics, let's say in Bucks Pediatrics. We just enrolled Bucks Pediatrics, right? So I enroll him in Bucks Pediatrics. One of the things we know is when we enrolled Bucks Pediatrics, all of the physicians were enrolled from bulk enrollment, from individual enrollment, but somehow Dr. Adams wasn't on there, right? So we recognize that by indicating, as you say, save and continue, you can see that the PCP is created, but he's not confirmed yet, right? Meaning that we know Bucks enrollment is an active clinic, but we didn't have Dr. Adams in that clinic. So because PHI belongs to a clinic and not to an individual PCP, CPAN staff are not allowed to share any PHI with Dr. Bucks until we verify that he is indeed part of Adams Clinic, or part of Bucks Clinic. So Dr. Adams will not have any PHI, even about the patients that he has called in before, until we verify the identity of Dr. Adams and his affiliation with Bucks Clinic. So I'm going to go through the call form. This is part one of the call form. I now know who the PCP is. I am going to ask, is this regarding a specific patient? Yes. Have you called in about this patient before? No, I haven't called in, right? So I'm going to have to do a new patient enrollment. I won't be able to get through this process without doing this, because gender and date of birth, whether it's an identified patient or unidentified patient, gender and date of birth are required because they matter in the type of consultation that we provide. Now, we ask for an MRN, and it's recommended that we take that information, last name, first name, and any ethnicity information are also optional. Many PCPs have indicated we don't want to share my patient's identity. We recommend MRN. So here, let's say a PCP says, I'm not interested to share any identity about my patient. I'm going to say confirm. Now, this is a script that the HRI staff member is supposed to actually provide to the PCP, which is, okay, you can share nothing, but if we move forward with this call and you call back about this patient is no longer available. It's actually gone into aggregate data for measuring metrics, but that if you call back about this patient, you can never access this again. You have to start all over again with the process. Typically, we've seen more encouraging results where they say, okay, I will share my patient's, oh, I didn't do that, sorry. This is unidentified, it's okay. But you can typically, what we've seen is they go back and add the patient MRN information. So in this case, I didn't. So this information is gonna go into kind of bulk data. But if you add the MRN number, when they call back about this patient, you can always track that patient back by the MRN. And the difference between MRN and personal information is that MRN is only attached to that clinic. So our system recognizes an MRN only based on the PCP and the clinic that has provided that MRN. So if, let's say, that number is let's say it's, the Texas Children's Pediatrics, TCP, they've actually shared an MRN, and then UT Pediatrics also has the same exact MRN in their EMR. It will never get mixed up because it's only associated with that clinic. So it's always secure and safe, and the privacy is protected. Is this call regarding an emergency? I'm going to say yes, it is. It is an emergency. I am talking, this patient has, a possible, is threatening physical safety. But part of the script I'm supposed to provide is that, we're not an emergency call center or and we don't deal with any emergencies, and that we refer them back to follow the emergency protocols of their clinic. This doesn't mean we won't call them back, right? It only means that they cannot call us if they have an emergency. They need to go to the nearest emergency, or recommend that their family goes to the nearest emergency room, or call 911, or call 911 on their behalf. But we are not going to be the entity that handles that. I am, however, going to say this is regarding a physical safety, and I can call here and say patient is threatening violence towards family, for example, right? This is the note I add in here regarding the emergency. So given what we're seeing, this is most likely around behavioral management and potentially medication management for this patient. And I can say here, family requesting support on how to manage patient at home. This is something that I can see, and updated medications. So for this particular, even though I am a psychiatrist, I'm going to pretend I'm not, that I just picked this up as a referral, as a resource coordinator. And I'm going to assign this call to a psychiatrist, because the minute you click medication management, based on those roles that we have defined and all of their functionalities and permissions, no one else in the HRI team has access to do anything on medication management. If it were only behavioral management, you could also possibly refer this to a therapist, right? But in this case, because it's medication, it only can go to a psychiatrist. And I can add my notes, whatever they are. These are general notes about the call. Obviously I'm going through this very quickly, but the call typically involves some additional description that's coming from the PCP. I can add that information on here as my general notes about the tone of the discussion, and then submit the form. Okay. So here you can see, I just created a consultation follow-up. So I took the part 1 of the call form, I submitted that form. Now, as a psychiatrist, when I come in here, I see that a call is awaiting consultation for behavioral management and medication management. And the call came in just now, right? This call can go, this counter will go up to 30 minutes before it starts to say it's overdue. So I'm going to take this call now just because I added it. And you can see that I actually have the information about the PCP here. I'm going to say, the first attempt, I wasn't able to connect with the PCP. Right? If I update my, oh, I know what happened. So I didn't update I didn't refresh my page, so it's not showing it, but I'm going to continue the call. It will give me a 1 callback, missed callback. But I'm going to continue the call. You've seen already what that feature looks like. So I'm going to say yes. And I'm going to continue the call. I reached the PCP. I continued the call. As you can see here, it indicates the PCP is pending verification. So I'm not allowed as a psychiatrist to share any PHI information, or it's notifying me to not share any PHI information with that patient, with that PCP. The next thing I need to do is I need to make sure that the PCP is who they say they are, right? So let's say I'm Johnny's mom, and I'm calling in to see what that call with the PCP was all about. So as a result, if I call in and I'm not able to verify my own identity here, again, whoever is on the call recognizes that they cannot actually share any PCP, any PHI information. So it says no PHI can be shared if you can't confirm both of those identities. Here, I'm going to say I am, in fact, Dr. Adams, and I confirm and continue the call. Again, reminds me not to share any PHI. So this is now part 1 of the call form in a read-only format. So I can't change anything here, right? I can only look at what information was provided during the first part of the call with all of the notes that were here so that I understand what I'm supposed to do when I'm taking this consultation. I know it was referred to me as a psychiatrist, and I read the general notes, and then I go to part 2 of the call form. So now this is where traits, really databases that have been kind of the foundation of all of these applications come in. The rest of it was really customization for the CPAN program. This is where the data actually is already stored in the data platform that we've created. So I'm going to say, so I am now the psychiatrist. I call the PCP. I say, okay, so what is it what symptoms are you exactly seeing? The PCP explains, the family is describing aggressive behaviors. You can see all of these as soon as you start typing is pulling information from the database. The patient also has some sleep issues, difficulty falling asleep. The patient is showing some social withdrawal. And these are, let's say, the 3 chief complaints, and maybe has some attention, poor attention span, right? So these are all, again, pulling from the, kind of the multifactorial data set for all the symptoms. I can even ask for migraine. Patient suffers from frequent migraines, right? Has the patient been, I'm asking now as a psychiatrist from the PCP, has the patient been diagnosed with any prior, disorders? And the physician is going to say, yeah, the patient has had a history of ADHD and has been diagnosed with ADHD. Is the patient seeing any therapist right now? Yeah, the patient is seeing Dr. Samuels in their kind of surrounding area. Now this, as we collect this information, we're actually creating a registry of all of the different resources in all of the regions that people are currently seeing or that we have connected with. And then eventually this becomes a much more automated process where if you're trying to make a referral, you can search that registry by services or by name or by zip code and provide resources to patients as this registry grows bigger. Right now, we're only creating a registry based on what information we're getting or what the outreach looks like. Is the patient on any medication? The physician is going to say, the PCP says, yeah, the patient is on Adderall. And he's on 1 pill daily in the morning and 1 daily at noon. And that's the medication the patient is currently taking. And then I add my consultation notes, patient notes based on conversation, right? So I'm having a dialogue with the PCP where he's describing a whole bunch of other stuff to me. I'm adding all of my medical consultation notes here. And based on all this information, I now am ready to make some recommendations. Now here, I also have, not today, but in the next, in the future release, what you will have is the ability to say, based on the information, I kind of know what I want to say, but I need to send maybe a standard measure. Let's say maybe I want to send the PHQ-9 or the SCARE to the PCP or directly to the family if I have enough information. in order to get some more data on what the real symptoms are based on those standard measures before I make my recommendation. That feature is actually in trait. It hasn't been turned on for CPAN yet. We wanted to make sure the call consultation is completed, everyone is able to collect that data, and then we add that feature in. But that feature is in use right now, for example, at Texas Children's Hospital. Do you recommend diagnosis change? Yes, I do. Based on what I've heard, I'm going to agree that this patient probably has ADHD. I'm not going to dispute that, but I could disagree with the diagnosis. If there was a depression diagnosis, I could say, no, I disagree with depression. And add here that I do have a suggested, maybe there is a social anxiety disorder that I want to recommend. I'm going to say, you know what, based on what I hear, I think this patient might also have a social anxiety disorder. And I'm going to add my reasons for the recommendation, right? And as I'm describing this to the PCP, I'm typing up my notes on why I'm actually making this recommendation. Now, these notes are for future follow-ups about the same patient. It is for the next person who may be taking the call. I may be referring this to somebody else after I'm finished. So as much as I can, I want to document everything that I am actually suggesting here. And also for educational purposes, we remember what we told the PCP last time, so that the next time they call, we can actually tell them, well, this is why I said this to you last time. It kind of continues the mission of why this program is here. Do you recommend a medication change? I'm going to say, yeah, based on what I'm seeing. Number one, do I want to change anything here? I'm going to say continue at current dose, so I'm not touching the current medication. Or I can say, my recommendation is you can probably reduce the dosage or change something about the actual medication or remove it altogether. In this case, I'm going to say, okay, yeah, just continue at current dose. But I am going to recommend that you may want to write another prescription for, let's say, Zoloft, given the symptoms this patient has. And I'm going to say, take 1 pill daily in the evening. And I save that. So now you can see that the medication that the patient is on is here. I've agreed with that and said, don't change anything. But I'm recommending, again, I'm not writing a prescription as a psychiatrist here. I'm just saying to the PCP, I think based on what you're telling me, you might want to consider providing Zoloft to this patient in order to reduce the anxiety level and address some of the depression and behavioral issues that the patient has. And here I may add reviewed with PCP, revisit symptoms in 3 weeks. So basically saying, if you'd like, call us back in 3 weeks. No interaction between Zoloft and Adderall. Like, I'm just going to add some, it's just general notes I am actually adding in. Do you recommend diagnostic tests? I'm going to say yes, right? Am I going to, so for a psychiatrist, I can recommend anything I want here. If I were a therapist, I would only be able to look at the psychiatric evaluations or psychological evaluations. I would not have access to prescribe any labs or imaging, for example. Here, I'm also going to say, forget about anything else. I just want to recommend some general psychological assessments. If I wanted to, I could also specify something else, where in here I could say, I'm recommending X, Y, and Z. And in here, I can again say add details about the assessment I am recommending. Does the PCP require referral? Yeah, they do, right? Because I'm actually recommending a number of different things here. So I'm going to say the PCP, given the symptoms that I'm seeing, we should recommend a referral to a child and adolescent psychiatrist within the surrounding community of that family. I, as a psychiatrist, believe this family also needs to take some individual therapy. I'm going to say BCBA and maybe some CBT. So again, you can see that these are all coming from the kind of the data platform that Trait has already created. And you're going to maybe even possibly recommend an IOP program for this patient. I'm going to kind of pass through here and not, as you can see, there are many different resources and other types of referrals you can provide. The next question is, are there any referrals by, can any of it be handled by the LMHA in that area? I'm going to say yes, right? And the services, so you can see the 3 services that I'm recommending show up here. And I'm going to say the psychiatry specific, the kind of the child and adolescent psychiatry services can be handled by the LMHA. I have the option.
Question.
Yes.
Are you planning on developing like step-by-step videos so that way as we change staff, people can watch this and as part of their training, etc.
Yeah.
If so, and that's great. And I really want to commend you. This is amazing, absolutely superb job. Is it possible to kind of like skip things, the more big things versus step-by-step, demo of the entire platform? So that way we can, see really relevant things for us as the executive committee. And then maybe the smaller demo, more detailed demo could be done for the CPAN group, or set up a separate time for that and the video as well.
Sure. So this is basically now completed actually. But yes, of course, let me, so do you want to go over other items here during this particular session? Is that what you mean?
I mean,
if we could hit the highlights, we're going to be running a little bit short of time.
Oh, I see.
The other conversations, so I think we do need to wind up the demo.
Okay. Yeah, for sure. I can actually, so I'm just going to complete this consultation, I guess. But you would see that there are additional phases to this. I can refer this to, for example, to a resource coordinator to complete this process. But at this point, I'm going to say consultation complete and maybe pick one LMHA and continue. So I'm done. This is kind of the evaluation form that now indicates I'm done, completed the consultation. This call is now in the archived and completed, part of this process. So to answer your questions, the highlights were actually exactly what I went through more detail. My apologies, I thought we had an hour, but I guess the only thing is, the enrollments are completed, all of the verifications and validations of opportunities to share PHI are completed, and the call form is completed. We have trained all of the HRIs. We have recorded all of the videos, and they have a step-by-step document as well. And they each have a link to a folder where all of this information specific to their HRI is stored. So they already have access to all that information.
Thank you. Malachi, again, I echo Alex's statement. I actually wanted her to show the executive committee, so apologies to Malachi, I said, because I think what I really wanted to show was the thoroughness of the data collection, and actually that we really very clearly built it to make it be efficient. So although she's spending time kind of showing it through, when you're on the call with the provider or with the clinic, it's actually a very efficient process, because we want it to be very clear with Barry, Sarvet, and others with other state programs that you want data collection, but you don't want it to be sacrificing the busy PCP's time. So I think this is actually a very happy meeting between getting a lot of data, but also not being efficient on the phone call as well.
Yeah, I think this has been really helpful, and all the components of it, to me, look really, really good. And so, but let me let the folks that are on the call react to it and give you some feedback. But again, I really appreciate the work, and I have a much better understanding because of the details that you've put in so far. So thank you very much. Any questions from our executive committee?
I think it's excellent and so smoothly, so smoothly done. You can just zip right through it. Creates things. It's so relevant. Putting in medications that easily. I wish our medical records were like that. So fabulous job.
Thank you. Thank you so much.
Any other reactions or questions from our group?
I can't wait for us to get started doing this.
You're almost there. I think we have a training session set up for you.
You do.
Yeah. We had one already with your team actually, so it's coming up.
This looks really great, Maliki. Thank you so much.
Thank you so much, Dr. Soares. It's good to see you again.
Good to see you soon.
Yes, I mean, we've been working, I mean, their team has been working around the clock since basically March. And so they had to build this completely from scratch. And I think there's always tweaks and we're getting those improvements, but I think we've definitely hit the mark and they've met all their milestones, and we're very just so appreciative of the work that they've done for the state.
Thank you. And your team has been really great. We've met every day to make sure that we're on target. So it's been great that we've had your support. Thank you so much, Dr. Williams.
Thank you. So are we ready to share screen and sort of move to just the business of COSH?
Yeah, just quick double check. Any other feedback? Hearing none, again, it sounds like everyone is very supportive, and I think they're, very anxiously waiting to be able to use it. So thank you. And I think, as Dr. Vo noted, some training videos to go through what you did right then would be really helpful to folks as we're bringing them on and off. And but I appreciate the thoroughness, because it shows me from all the different perspectives kind of how it's pretty easy to use and very intuitive. So thank you so much.
Great. Thank you so much. That's what we'd like to hear.
Yeah.
Thanks so much for the opportunity to demo. So I guess April and I can get off the call now.
Yes.
Great. Thank you. Thanks, everyone. Have a great day.
Thanks.
Bye-bye.
Just stop sharing your screen. That'd be great.
Okay.
Yeah.
Awesome. So yes, I did want everybody to see it, because there is a lot of data that we'll be able to get. The dashboards that each of the HRIs will be able to have is going to be extremely thorough. And so there's going to be a lot of opportunities to work on our engagement, our enrollment, our education, both by the PCP at the time of the call, as well as thinking of ways to help engage and educate beyond the call itself. Sorry. Last time I had problems with my screen, and it looks like I'm doing the same thing as I did last time, but it's gonna fix. There we go. Okay, so this is the report for August. Myself and Jennifer are going to speak. It's definitely been a whirlwind, as everybody's noticed, thankfully. Although it always feels bad to say you're glad the storm didn't hit us, because it hit other people. But when I was doing these slides, it was looking like maybe Houston was going to get hit. So thankfully, Godzilla moved on, and hopefully the families in East Texas and Louisiana are going to get themselves pulled together. We're going to go over telecommunications, data management, CPAN TChat specifically, and then the statewide referral system, linking in all the things we've talked about with referral system, including the thing we heard this morning around OB-GYN as just sort of an idea. So obviously my summer term of plans have been about being on the computer. So the tele updates I sent out, I'm not going to, in the interest of time, I'm not going to go through every single attachment that you were sent out, but I sent out attachments. The Lantana project team has been working with each of the HRIs. We've met with all except for one. 50%, we're through half of the steps that need to be done to get the project running. The decision has been made to not go live with the full Lantana process until all the teams have their setups. This week, Baylor, as sort of the COSH hub, is going to work on using the software, the soft phones, and learn how to use them. Start providing some help with feedback to Lantana about how it works, doesn't work, so that when we're ready to go live, we can have that go well. The Lantana team itself is going to actually train. So to Alex's point, I'm not going to train you on how to use the phone. I barely know how to turn on my phone. So the Lantana team themselves will train each HRI on how to use the system. That's part of the sort of build and ask from them. So right now, even though Baylor's going to go live this week with using the sort of soft phone process, we are still going to use our team in the same way that all the HRIs are using right now. So nothing changes about that. There's no impact to that, but we are going to start using the Lantana product to, like I said, hopefully be the beta testers and have it, ready to go for the other HRI teams. We also, there's been a lot of back and forth around this issue of sort of the close proximity with UTMB, UT Houston, and Baylor as far as our teams. So we're probably going to have a sub menu that will prompt the PCP to pick between the three of us in case they're calling. But we're going to talk that through to make sure that everybody's happy with it. It's just because there's some intermixing around these areas, even we just want to make sure that the call gets to the right team. We don't want to have people be unhappy because they're not getting routed to the right team. So we'll be having direct conversations with UTMB and UT to make sure that everybody's happy with that. So just an FYI about that. And so we're not going to be like cats. We're actually going to be very helpful. If you are struggling with anything around Lantana, as far as we know, you have to add your IT and security and telecoms team members at your HRIs. If anything about that's not going well, please let Jennifer and I know so that we can help you kind of through that process. We're having our own fun challenges sometimes at Baylor, so we imagine it could be happening for you. So please remember that the COSH team is here to help you with that. Questions about Lantana? We had our big state meeting on Friday, so all the teams that are doing CPAN got a lot more sort of specific updates than the executive committee is hearing from me right now. So data management, all the NDAs and BAAs are complete for the CPAN project, so I really very much appreciate all the hard work everybody's done around that. As you can see here, I started to make new slides, then I realized, hey, let's let everybody reminder all the steps where we've kind of gotten. So we got all the NDAs, BAAs, the enrollment process, including how to do bulk enrollment, has been completed. The phone call rollout has started. As I said, they're doing the trainings right now with each HR team, and the goal for TRAIT is to have that done within the next 2 weeks. And then I said they're going to start building out the phase 3, which are the scales that PCPs can send to families. And again, this is already something that TRAIT does, but we're going to do that process last because the aims of the consortium were to do the other pieces. This is an add-on bonus that the state of Texas is getting for their bang for their buck, for lack of a better word. So that'll be the last step that kind of gets going when it comes to the TRAIT rollout for CPAN. Data management for TChat. As we've talked in the last few months, you know that as the TChat sort of state teams started getting together, working together, there has been an agreement across each of the HRIs that they would actually like to have TRAIT do the data management for TChat as well. I hope everybody recalls that that was not necessarily the case several months ago, that there was still not clarity around how much there was going to be consistency for TChat. But now that we've kind of gotten to that point where there is consistency, we are working with them. And so that does unfortunately mean there has to be potentially some new arrangements with data privacy and security. I am talking with Christina and Michelle at the UT system broadly. We've actually had in the state meeting as well for TChat a conversation about that. So we are working on sort of the next piece of the legal process around that. I'm hoping to have some information that will close the loop about what was needed this week. The TRAIT team has agreed that they can actually have HRIs up and running potentially by next week or the following week, as long as we first answer this particular question, because the TChat program that is needed, the data entry, a lot of that piece is already built in TRAIT, and so there will be a separate build out I'll talk about in a few minutes. But as far as getting us to do the scales right now, that could be something that could happen as early as next week or the following week. So we had a big demo. Again, for those of you who are interested in see the demo, it was recorded, and we can certainly share that with people. We are already planning with that data management piece. Initially, the initial RFP for TRAIT was to actually do an integration of TChat into CPAN. So for families that do give us permission to do that, even before we were having TChat for TRAIT, we were still thinking anything that TChat did, we would find a way to do some integration. It'll be a different and easier integration now that TRAIT and TChat are going to actually do the work together. But nonetheless, the goal is, that idea is after TChat team, let's say that 5 times fast, sees a family, as a family would give us permission, we would send sort of a discharge summary of TChat to the PCP. So the PCP would have that information. And then if the PCP calls us in the future with CPAN, then that information that was provided to the PCP would be something the CPAN team could see and then act upon to continue the education and some guided support that's involved with CPAN. So again, that would be some seamless data as long, with parental family permission, obviously, always with parental and family permission. I know I'm speaking fast. Are we good there? Data governance. Again, I did send some of the documents. I'm not going to share screen in the interest of time, but some of the documents that you got for this meeting today include some of the work that the governance team that Alex and Dr. Pliska, sorry, Dr. Pliska, I have to call you Dr. Pliska. I'll get better at it. That they're sort of co-chairing this particular team. I'll try. And so we have done sort of the first step. So you should have seen an Excel spreadsheet that was the data points that you just heard from the the trait team just a few minutes ago. And we also, the trait team was already building definitions for each of the data points. So they've actually done a fair amount of our work for us. Molly's team has also provided some of the metrics, the data collection points that her team's going to be doing, and started to build that definition as well. And then Dr. Pliska, sorry, did the same thing for the CPWO. And so we're going to start working on those. And so I don't know if Alex or Steve would like to say something now. I'll pause.
Yeah, I think the only thing is we have three major tasks in front of us, and that's really to create an inventory of all the initiatives and the data that we're collecting, and then deciding where the overlaps are, and et cetera. In addition to that, the second major ones is essentially developing a data dictionary, data library, outlining and validating where the source of truth is, data sourcing. And then finally, the big task, was probably not going to take place for a few months, is really after we've been able to develop all this, is to essentially create policies around stewardship, integrity, security, all those other things. So those are the big three buckets of work that lies ahead of us in the next few months.
So yes, we're hard at work with Alex and Steve's sort of direction, and so we've got off to a reasonably good start. We'll be doing the same thing that we did for the CPAN that you saw attached today for TCHAT, and so we'll allow for the executive committee to review that information, hopefully at the next meeting. It's definitely not data magic is required. I wish I could wave a wand and have it there, but it's definitely work everybody's doing, which I appreciate. So moving on to just progress of the two programs, we have about less than 5%, I would say, of PCPs enrolled across the state of Texas. This is in part, remember, some teams are not functioning yet, so they've not been necessarily out and engaging and enrolling. But we are steadily growing each day. There's more and more, even probably from the last time I put these slides up, there's been some more. So individual providers registered in CPAN, clinics that are registered, and then we are still averaging around 2 to 4 calls per day, which of course is not where we want to be. But this is where I also pause and remind us all that it took Massachusetts 18 months to be fully busy and post the kind of numbers that we heard even for the MOMS program this morning. So, Rome was not built in a day. And I do think we're making progress, and we'll sort of talk about that in a minute. But we are excited that we're still getting calls. And actually, we're getting repeat calls. So PCPs who've called once and they've liked the program, and they call again about a different, kid and family. So we're excited that it looks like people are happy with the program. Without all the sophisticated data that we're going to see with trait, we do have some sort of more, for lack of a better word, straight vanilla data. And so that's what I'm going to share with you here. When you look at the severity of the problem, so this is our team kind of thinking, how severe do we think the problem was based on what the PCP told us? We see that, the majority of the cases are considered moderately severe problems that they're calling us about. Simple, mild is the next largest chunk at 29%. And then again, the complexity of the question as rated, again, that very last slide, I think that Malachi showed you, is us kind of thinking, well, how complex do we think this question was? And again, at least our current sort of metric for that was that it was, from our perspective, a somewhat straightforward question. So these are just these are not the sophisticated analytics we're going to get moving forward, but this is sort of what we built in with the red cap as we are waiting to go live with trait. When you look here, once the PCP calls, who are they asking to speak with? 36% of the time they are asking to speak with the physician. And then the other sort of next largest chunk is the resource coordinator to find some resources in the area. We're having less calls about actually behavioral management at this point, but it's still not a small chunk. So I think we're actually getting basically what we kind of expected and hoped with based on MCPAP and other programs, that they are calling for a variety of issues, not just one thing. And then when you look at the reasons for the PCP calls, you can see, again, the larger chunk is 28% is medication management questions, followed after that by referral assistance. So again, it sort of tracks, even at the small sort of step of CPAN at the beginning, with what we heard from MCPAP program as far as the reasons for call and what we hear from other state programs as well. And then when you look at the medication recommendations, we can see here that the larger percent is that there has been a recommendation to potentially consider a new medication, and then follows shortly thereafter with potentially no recommendation. So at that point, what that to me says is that we're actually recommending a different kind of intervention beyond the medication. As a child psychiatrist, mental health person, we know that a lot of the recommendations for care for young people involve, evidence-based psychotherapies or other kinds of support. And when you look at when there is a referral that's asked for, about 55% are to refer to a behavioral health provider, not just to a psychiatrist. So again, that larger number is actually looking to try to help those team members find providers that can help the young people besides a psychiatrist, and then 23% are to a child psychiatrist. Questions about the sort of small amount of data that we have to this point before I move on? So I think, again, we got the reminder this morning with the McMoms program about the idea of how do you make these programs work across the state, across the country, is through building relationships. So those communication strategies we've been working on. We have state level communication strategy. That's what I'm talking about primarily today. We do have the video that Dr. Tran and I created. We're still waiting for 2 HRIs to give us their logos so we can add everybody's logo to the video. We're hoping that we can get those maybe today, if possible. And then within the week, that video should be completely edited. We do have the Facebook page. I was going to flip to it, but you guys, I'm not going to do that because it'll take too much time. But please, please, please go to the state Facebook page, look at it. It's been beautifully done. I commend Hethel Modi, our team member here at Baylor, who created it for us, and then also Dan's team with all the lovely graphics. So make sure that you're sharing that page widely, linking it with a bunch of other teams. We've also talked about each individual HRI can have their own Facebook pages, of course, and other ways to communicate through media based on each individual HRI's recommended modes of sort of mass communication. Now that we have this Facebook page done, we are working. Our next step is LinkedIn. Those were the 2 platforms that we were given permission to do at the statewide cost level. We have a TPS contract, that's the Pediatric Society contract, completed. So we're going to start doing some more targeted interventions to the pediatrics. They allow us to do things through their email listserv. So that's one of the things we're looking forward to. I recently gave a webinar through the city of Houston around COVID-related issues. I did talk about CPAN and TChat in that, and to date, there's been over 4,000 views. One of the things that we like to tell each of the HRIs, if you're doing something like a webinar in your HRI, send that to Hethel so she can put it on the state Facebook page and everybody can view it and see it. So if there's things that you're doing that we would even mind having it be outside of your HRI regional hub area, let us know and we'll put it out to the state. We are building the purchase order right now. We are going to, with COSH funds, so again, different teams can use your own communication outreach funds to do things at the HRA level, but at the state level, we've gotten approval to order magnets, pens, and scratch pads that will all have the CPAN logo and phone number on it. Each HRI will get 1,000 magnets, 500 pins, and 500 scratch pads. I'm hoping to have that within the next week or two to everybody. So that way, hopefully now that COVID has perhaps, we're on the, maybe on the downside, we'll be able to start going and talking to people maybe in person, and you'll be able to bring some of these information around education about the CPAN program. We do have the 4 teams working on content for the page. So Dan's team's working on making it be stand out so that PCPs or whomever can get the information. And but we're working to have content experts across our state. I have obviously great team members across the state, and so we have an ADHD, depression, anxiety work groups along with the face page work group. So our hope is to also potentially have podcasts when we're thinking about what is a good way to communicate with PCPs nowadays. One of the things that we thought about beyond sort of the written word on a web is also to do some podcasts that are brief 5 to 10 minute chats that would actually model and mirror the kind of thing that they would have if they were to call CPAN. So we're really trying to help reinforce this idea that CPAN is simple, it's on your time, it's not lengthy, and you can get some good education out of it. And so we had a naming exercise, and so there's a potential winner, whoever, I don't know who it is yet, who came up with the idea of Mind the Chat. Apparently another sort of company or somebody uses that. We're checking to make sure that it wouldn't be a copyright violation because we really like that one the best. It really connects with this idea about what CPAN is. So hopefully it's something that we'll be able to use and call our podcast Mind the Chat. Anything about CPAN before I move on to T-Chat?
Laurel, this is Sonia. I was just curious, what's the volume so far of calls that you've received?
It's about 2 to 4 calls across the state per day, so it's still very low, and we certainly want that to be improved. The HRIs are doing their own work at the HR level. I was simply talking about what we're doing at the COSH level, but know that everything that I'm doing at the COSH level, the HRIs are doing themselves. I have spoken to national CPAN teams about how they went about engaging PCPs, and at this moment in time, I don't think we've left any stones unturned, although I'm always happy to hear new ideas. It's really this idea that we are competing with summer, which is already slower for primary care for children, and then COVID. So I think we just had a little bit more of an uphill climb right off the bat that we had, a little bit of control over. But I do think that as COVID, unfortunately is going to stick around, but as we're able to actually go out and meet with practices, I'm hoping to see that number steadily climb.
Thank you.
Mm-hmm.
And I agree, that the numbers aren't where we want them yet, but if you talk to the pediatric, practitioners across the state, overall volume for everything they do right now is low. And with schools out, shouldn't be surprising that the referrals are not coming in at the volumes that we believe they will be coming in once schools start and people start seeing their pediatricians again. So we'll keep watching those numbers very closely and continue to do all we can to get the word out and register individuals and continue to build the programs.
Yeah, and I really go back to the morning speaker. It's really about building the relationship, and that's it was always one of our bigger thoughts is once we get a big area and how big the state of Texas is, how do we really encourage that relationship build? So we have a couple of different strategies that we've been talking with both with the state CPAN teams, and then they're also coming up with cool ideas as well. So I think that we're going to get there. But I also I wanted to remind everybody that MCPAP has been running for almost 17, 18 years. They've had a long time to really be well established. We're just starting. So I'm not worried. I think we are doing all the right things, but I'm always open to new ideas. T-Chat. So as I said, T-Chat is standardizing. We had our meeting on Friday where the trait team showed them what is possible for a trait to do with T-Chat. Hopefully people were enjoying what they saw. It was video recorded, so others can watch it if they would like. Within that standardization, we're working on a consent process that talks specifically about the time-limited nature of this care, prescribing guidelines and best practices that we can hopefully share across the teams that are going to be prescribing medications. There are a couple of TCHAT teams that are still feeling that they don't want to prescribe. They're going to do sort of a slightly different process, but nonetheless, we want to have something that looks consistent across the state. And then also that we want to have some consistency across the state about how we may management of emergent issues who are receiving the services, not so much at school, but for those kids that we might be still seeing at home, to make sure that we really have a really robust and good response for if a young person is in crisis and they happen to be at home and not at school. So we did ask for TRAIT to give us some pricing estimates for the build out, because again, please all remember that when we asked for the initial build for TRAIT, it was primarily a CPAN build and then an integration of any data that came from TCHAT. Now that we're actually asking for TRAIT to do the TRAIT, the state metrics along with patient tracking, they do need to build that. It's actually not going to be a complicated build from their perspective because it's already built on what their team does. CPAN was completely from scratch. This is making some modifications to their ongoing platform, so it will be a much shorter turnaround time. But I did want to be clear that it would be additional dollars that we're looking to ask the state for. The other big tool that we potentially asked TRAIT to look at was whether or not they could do a screening tool that would be available as an entry point, so before TCHAT. And again, they actually did some estimates, and here's the other estimate of a one-time cost. So these are one-time build-out costs. These are not recurring costs. And I think that both of these particular build-outs would be in mission and in line with what the LBB is wanting when it comes to providing referral and actual care assistance through schools. So I think that that will be a conversation that Dr. Lakey is going to be leading, it sounds like, in a little bit, but I did want to give everybody those price points for the build out specifically around TCHAT.
Hey, Laurel, this is Andy. Can I ask you a question about the screening tool?
Yes.
Where will the data reside? So like if I'm a parent and I take a screening tool for my child, where will the data on the screen results reside?
With the HRI, not with the school.
So it creates, it'll go into the electronic medical record the HRI keeps.
It won't be in the EMR. It will be in the TRAIT digital cloud platform. It will not be in the EMR. Until the family were, again, there's an issue of EMR integration, which I have not brought up. Right now, TRAIT does not connect with EMR, so this is just data that would be sitting at an HRI for their team to review.
So it'd be accessible just to the HRI with the program, just between the family and the HRI?
Correct.
And would they would have a relationship with the HR when they filled that out, or the screen would just go whether or not they ever received a TCHAT service?
Yes. So we would want to talk about what that would look like. So right now we haven't gotten into the nitty gritty, but what we've talked about this idea that they have not established care with us. So the family would get sort of an initial sign-in or face sheet that explains what the screening tool is, what it does, what it doesn't do. And so families could choose to use it or not, but it wouldn't be something that people were required to do. But it wouldn't promise a care service just by virtue of the family filling it out. But it would potentially ask for a family, would you like to be contacted? And so a family could say, yes, I do, or no, I don't. Or my guess is if people don't even want to be contacted, they wouldn't even do the app in the first place. Yes, but yes, those are things we'd have to talk about, but we wanted them to kind of just give us potentially an estimate if we wanted to build sort of a screening tool, what would that look like, since we knew that there may be some funds that are, possibly up for one-time build-out costs.
Laurel, is there a distinction between a screening tool and an intake form? Like once they've consented, isn't TCHAT also developing an intake form, like the traditional thing that people, and those are two separate documents?
Well, the way that this could work, if we ended up building it, was that it would be, again, a tool that the family would fill out. And if they screened positive for anything, the family would be given options, including, would you like us to make a referral through your TChat if they have, a TChat service or not. So the idea is that it does need some work to think it through, but it is definitely this idea that until, if they say, well, I don't want to be contacted, I don't want to be bothered, we wouldn't be contacting them or bothering them. But I imagine that more often families will read it and go, yes, I want to do this. And yes, I do want to be contacted if I need a resource.
Hey, just want to say that these 2 quotes are quite reasonable in my opinion. Just to lend that.
Thank you. That's helpful.
Yeah, Laura, I would just add, just for the record, that, while I think a lot of families would feel that way, there's going to be a subset of families and parents who are extremely concerned about this. And so we want to make sure there's a very clear consent process and a very clear security protocol that we all, feel is rock solid. And so I think we need to think of the whole range of parents and families out there, many of whom are going to value this, but many of whom are going to have legitimate concerns that we're going to need to bend over backwards. So I think the $52,000 is an excellent cost for building it out, but I think it really depends to me on the consent and privacy protection components that we would have.
Well, and that's one of the reasons why we wanted it to be clear that it wasn't sitting at the school, because again, if a family didn't want their school to know anything about their child's health care, it would be sitting potentially with a health-related institution, academic center. But yes, I agree. How we would build the process of informing is very important. And obviously, the biggest option is for families to not use it all. Say, once I hear what this is, I don't want to use it. And then they're not being forced or asked to do it, something that they don't want to do.
Why don't we move on? We have about 10 minutes max before we need to go to the next subject.
Well, we're at the last 2 slides, so I think we're good. I was kind of moving quick. So I'm actually going to stop talking now. Again, you got another, I'm not pulling it up, but you got another form from us that was sort of a comparison between WellNeti and Aunt Bertha as far as statewide referral system. I can tell you that both WellNeti and Aunt Bertha, if we ever were to move forward with anything related to moms for care, that the statewide system would still work for that as well. So I'm going to actually turn it over to Jennifer Evans for a few minutes. She's been the one who's been spending the most time getting well up to speed with these 2 systems and what they may be able to do.
Good afternoon, everyone. I'll just go really quickly through the handout that you have. So WellNeti versus Aunt Bertha, I'm going to sum it up. Not only the cost is different, but the capability of the system is different. So WellNeti is what's called a crowdsource application, where it's in real time. So you can present a question to them and say, I need a therapist that specializes in CBT in El Paso. And if it's not already in the system, then within 90% of the time right now, within about 20 minutes, somebody answers that. And it may be that they know of someone who just started that. So if you have not signed up with WellNeti or with Aunt Bertha, but somebody knows of you, then in the WellNeti system, then they can just say, oh, I know of, Dr. So-and-so, she just, hung her shingle, started. And so, that's how they get people added to WellNeti. And so it's kind of a living, breathing thing. WellNeti will also do a more descriptive thing for us. So they can do a dashboard for us. They can make for the state where it is, we can invite our own group for CPAN, TChat. And then if we do the moms, we can do things just for that. So we can have our own dashboard. It can also tell you by location, insurance. It can do Spanish speaking services or not. And so there's a whole lot more to on a level where Aunt Bertha doesn't. So you have on WellNeti, you have people who 2 or 3 times a year go through all the resources, make sure that they are still providing those services. Aunt Bertha, they don't have somebody that does that all the time. WellNeti is going to integrate with some of the LMHAs, some of the 211s. And so they can also, for the LMHAs, provide a way, which I know they were interested in, provide a way to track how many referrals that they're using for the LMHAs. I know when I talked to Courtney Seal, she had talked about sometimes there's 100 different referrals for the LMHAs, but people only use like the top 20. This would help us track and be able to introduce the other 80 that people aren't using to the system and, kind of highlight them. So I think that the biggest difference, besides cost, is that they'll customize it more. WellNeti will. WellNeti is a newer company. They just started about 2 or 3 years ago. They're out of the UT system in Houston. And they just started this with a grant that they had. Aunt Bertha, of course, I think everybody is aware, has been around for a long time. WellNeti would have to build more for the state of Texas. Aunt Bertha has some more stuff in it, obviously, than WellNeti at this time. WellNeti can also integrate with Trait if needed later on, and send the referral straight to the PCP from WellNeti straight to Trait through Trait that way. So I know that was really quick. I apologize. I'm trying to get through with it.
This is for us. If we join this, we then can refer our patients out to all the therapists or the resources in the system.
Correct. And if we cover for each other, like through CPAN, say, Houston's covering for El Paso, then we would know those resources because we could pull them up through WellNeti. Whereas before, we may not know that. If we're covering for each other, we may not know the resources in another region.
Is it possible to add local mental health authorities and other providers to that, or is this only something that could be used for the university partners?
No, it's possible to add anybody you want to it.
Hey, Jennifer,
Yeah.
and I did not know if you answered this question, but this cost that you're showing on the screen, is this per HRI or is this a one-time cost, hub cost?
It's a one-time cost for COSH, and then it's recurring annually. So it's a one-time. So if we split it out amongst the HRIs, it would be about $2,200 per year per hub.
That would cover both CPAN and TChat?
Yes, it would cover all of it. Yeah.
So it actually reminds me a lot of the programming that they talked about at Massachusetts about the St. Thomas or whatever who manages their resource list, that this is what we're kind of talking about, is it would be statewide, whichever system we wanted to use, that everybody would have access to it, that would run through the COSH. It's this first one-time cost and then the recurring costs for having a statewide referral system.
WellNeti will be so cool to have.
So, I mean, I think, again, the biggest advantage I see with WellNeti is just how they've built their platform. It's a dynamic platform, as we've said. It allows for you to more quickly find a resource versus how Aunt Bertha does things. It's a little bit of a slower, static process, and it's how often they actually update their information is a little bit slower. But the downside, is that WellNeti is a newer system, and Aunt Bertha is obviously more established. So I think that was just one thing we want to be real clear about, the potential differences, advantages, and maybe disadvantages. So Dr. Lakey, we're done.
I just had one question about WellNeti, if you don't mind, Laurel.
Sure.
Is there any kind of real-time updating of their wait list or that kind of thing? Is there that type of integration with the service setting that's listed?
Yeah, so he had said that he can build that in. So he's able to customize quite a bit of things automatically. And I know the LMHAs had said sometimes they have programs that start and then stop at certain times. And they want to be able to put a start and end time on that. So they can also do that. So if you have a program that's only going to last for 6 months, it'll take it off in those 6 months. And so I think there's a lot of customizable things they can do. So they're already said they can add insurance, which I know is important to all of us for what type of insurance you take, sliding scales, commercial and all that. And he did say they would figure out a way to do the wait list piece of it as well.
Got it. And so, and that requires obviously buy-in or some behavior on the part of whether it's the LMHA or other service. So that's great that they're organizing that. Really good asset. Thank you.
All right. Well, why don't we transition now to the last part of our agenda for the day. Thank you, Laurel, for the update. Very comprehensive, a lot of work that's taking place. So the last part of the day, we're going to talk about the budgets, a little bit of background related to this discussion. We have, since the last meeting, our group at UT System has met with each of the HRIs independently to talk through their budgets and to try to share ideas across the institutions when there's unused dollars, how other institutions are using different programs to expand their programs, to build their programs. What are some of those maybe best practices or other ideas that we can share across institutions? And so Lachelle has done amazing work, I believe, talking with each institution, multiple conversations with each institution, and back and forth dialogue to try to get us to where we are today. Now, to be very open and transparent here, there's some decisions we're going to have to push to the next meeting. There was this thing called a hurricane that came into the state of Texas, and all the folks in Houston and Galveston, those discussions had to stop as they evacuated out of the community and then returned to their community. And so some of the details on the budgets still have to be refined. We've received a lot of information over the weekend, even late night yesterday. Lachelle was in conversation with folks through email trying to pull this together. But again, that's not to be surprising. And again, with the hurricane, it shouldn't surprise us that some of the institutions were delayed. So Lachelle's going to present to us what we have right now. We've tried to, in each of these conversations, tried to keep as much money within the institution as possible. And we've tried to make sure that we keep a close eye on fiscal year 21 expenditures, that we don't incur an additional obligation by the legislature, but we also make sure that if there's an opportunity to use the recurring funds, we do so to make sure that we keep their budgets where they need going into the next year. Again, as we've been building these programs up, it takes a little while to get to that new steady state of ongoing expenditures. So there's been lessons learned for us as we've had these conversations on each of these programs. We're going to share that information as we go through. But Lachelle, let me start off with you giving the high level overview of where the budgets are and how do we need to move forward. Lachelle?
Sure. Can everybody see my screen?
Yes.
Okay, great. So as Dr. Lakey said, we've met with almost all of you, or we've met with all of you. We're still waiting to finalize UTMB, and we had a couple of minor changes on Texas Tech. So as soon as we get those final numbers, we'll have a better idea of what we're working with. I expect that UTMB may have some recurring dollars on the CAP fellowship side. That's to be determined. But as we are right now, we're looking at around 235,000 of sort of ongoing operational funds that we know of that people are returning that could be allocated to other institutions to either expand their programs, or it could potentially go to something like the COSH if it was for ongoing costs associated with systems. So we'll have to talk through that. And then as far as one-time funds that were not expended in FY20 for all the reasons we've talked about before that are rolling forward, that the institutions were not able to find, they didn't believe they would be able to spend it in fiscal year 21. We're looking at almost 4.5 million that is up for grabs, for discussion at least, as long as it relates back to the programs that have been approved by the LBB and it's furthering the objectives of those programs. So if I look at it from a program perspective, we can kind of very clearly see what we're looking at in terms of CPAN, TCHAT, CPWE, CAP fellowships. And I've also put what that percentage change looks like, because I believe in the LBB report, we said that if we go above the 10% mark, and these are all a reduction, except for CPW, these are all a reduction in the expected expenditure for each of these programs. And then as we start talking through some of the requests for additional operational funds and some of the proposals, we can shift some of these. So I do have additional levels of detail. I don't know that we want to go through all of that, but at a high level, we're looking at 4.5 million in one-time funds, 235,000 in operational funds, which would be reallocated, and that would follow into years 3 and 4, assuming that we get funded. Does anybody have any questions before I jump into the request for operational funds?
So maybe, Lachelle, before we jump into that part of the conversation, maybe it would be good to just give an overview to folks of some of those types of changes that occurred in individual institutional budgets where they've used dollars that weren't earmarked for a certain purpose, but saw an opportunity to, again, reinvest it in that program in order to improve its efficiency. Because I think there's been several themes kind of throughout these discussions. And, I don't think we're gonna have time to approve each individual budget, but let folks know kind of those changes that we've heard. Why don't we just kind of go through this list here and discuss some of those opportunities that we saw, okay? So I can start with that discussion. Okay, yeah, so with CPAN, again, things are revving up right now. Now, as we look at the data on who is seeing the most patients right now, a couple of themes have occurred. One is that a couple of our institutions used an outside entity to help them enroll practitioners into CPAN. And those that have done, their numbers seem to be going up quicker than other institutions. And so fellow health-related institutions have seen that, and some of them are very interested in duplicating that experience and again, using those dollars to rev up their numbers for CPAN. So, and for transparency here, again, I'm gonna be totally transparent that what Dell did in Texas Tech El Paso is that they hired Meadows Institution through other types of funds to help bring up those numbers, do that work, that legwork to get practitioners in. And other institutions are interested in doing the same in order to get our numbers up. They have also looked at how they could improve marketing through a variety of ways to reach more practitioners to move up those numbers. And there's been a couple of other themes there with, again, kind of general principles of how do you make these programs successful. Lachelle, anything that you'd like to add on that CPAN discussion of themes that we heard?
No, I think you've hit the main points there. I mean, the only other thing is about making spaces that are appropriate, bringing teams together, especially in the more rural areas. So making sure we have a space for people so that they can function well and provide those services.
Yeah, I forgot to mention that. I think I was going to mention it was that, but there were a couple of places where we heard from institutions that they needed to bring their team together into one functional geographic area to really make this work. And so there were some costs associated with that remodeling and bringing folks together. Dr. Nemiroff, it looked like you were trying to jump in.
Yeah, I just wanted to say that, speak on behalf of the help Meadows provided to us. It was just extraordinary and really allowed us to catapult the CPAN program. And I would be in favor of other institutions benefiting from that expertise.
Yeah. So the way that, and this is a little bit of an awkward conversation, but I really, when I look at the data, those that have done this seem to be seeing more individuals. I think Meadows is a little bit in an awkward position because they're part of our executive committee, and they don't want to be put in a position where it can be seen that they're directing resources to them. However, it is clear to me when I look at the data that those that have partnered with them to improve enrollment, their enrollment is up. So where I think we need to land, and this is open to conversation, is that instead of the executive committee deciding that if there's unused money, that we would use those for Meadows to do this statewide, if individual institutions believe it's in their best interest to approach Meadows or any other entity to help them in their enrollment process, that that would be a valid use of those dollars. Does anybody have a different opinion or want to say anything else about this part of this discussion? Hearing nothing, let's go on then to TCHAT and some of the things that we heard.
The only other thing I just thought of was Project Echo. That was the other one that we see pretty frequently in CPAN across the institutions.
Well, what can I say something real quick? You know, I think one of the things we need to consider as well, now that we've had a demonstration by Trait and some of the COSH presentations on the various tools that are being developed, you know, over time, we're gonna need to gather a lot of data, hopefully with this program continuing beyond just 2 years. And then there's gonna be a lot of different dashboards that's gonna be created to report data, et cetera. I'm wondering if we need to think about also setting aside some unused funds to start a data warehouse. So that way we have, you know, a source of truth for data that's archivable, that really records the historical activities of all the data that's being collected for the life cycle of this program, et cetera, versus having Trait, you know, hold it for us at one cycle and then, you know, other groups doing it for us, other third-party vendors. So perhaps we should also think about that as well. And that would actually benefit not only every HRI, but the state to have a major data warehouse that can be leveraged for different purposes.
So that's, I'm not going to disagree. I think that might be good. I'm going to put that a little bit in a parking lot, because I think first I want this discussion about how we tried to, within each institution, adjust how they're allocating dollars and how they readjusted. And then let's think about even when they did that, there were some funds that then surfaced that could be prioritized for a project like that or some of the other things that we've heard today. But before we get into that prioritization, want to make sure people understand the changes within institutions that occurred in their budget. Okay.
David,
so let's go.
Can I do a quick question?
Yep.
So when I think we all did this, when we did our budgets, we allocated things internally, as long as we didn't exceed our recurring costs, and then we had leftover funds. So I think of it, there are two pots of money. If we proposed a project and we funded it internally, and we're not talking about those necessarily, we're now talking about the excess that was left even when we allocated internally. Do I understand that correctly?
I think that's part of the next part of this discussion. First, let's talk about how institutions use dollars and prioritize it for their own institutional needs. And then we're going to talk through kind of then, even when you did that, as you said, there were some dollars that were still not used, and how we can think through those statewide initiatives or other priorities for those dollars.
Like for instance, just quickly, like we're looking at TCHAT. So if the number is going up or down, or what if people, that's what the institutions allocated internally.
That's right. That's right.
All right.
Okay. Okay. So Michelle, you want to talk us through the TCHAT budget discussions?
Right. So the majority of, I mean, everybody had leftover funds. The question was how did they want to use those, and how could they use it to benefit the programs. For TCHAT, a lot of people chose to shift around some of their teams if they were able to grab some resources from CPAN and shift those towards TCHAT. I saw some of that. I think as people have gotten the programs up and running, and they're starting to sign on schools, they're realizing that they may have been a bit heavy on the CPAN side and a bit light on the TChat side. I also saw for the one-time costs, a lot of people were building in technology costs to assist with getting technology out to the schools. That can be a reason why schools are not able to participate. And so they're trying to remove that blockage from delivering services. Also saw some Project Echo and again, some space type things, space renovations, and in some cases training, including development of training videos. And I think those are the bulk of the changes that I saw in TChat.
The other small change that we saw was that institutions, as they looked at their provider mix, have made some adjustments related to the number of psychiatrists that they need for the different programs. And again, as long as we could keep the dollars within those buckets of CPAN, TChat, CPWE, et cetera, I think it's not worth the time of this whole group to go through all those small changes. But we, working with the institutions, if they could keep them in those buckets, are telling them to go ahead and move forward with those type of changes. Okay. All right.
All right.
Go to CPWE.
So with CPWE, there wasn't, we didn't see as many changes. There's a couple of exceptions, but I think majority of people were just looking at changing their staffing mix. So either providers or administrative staff supporting. I can't think of anything specific with CPWE, maybe some marketing. But I would say most of the changes actually occurred within TChat and CPAN with a few exceptions.
One of the conversations we're going to have in just a little bit, though, is that a couple of our institutions see an opportunity that they can reach out to additional local mental health authorities using telemedicine type technology. Again, they have already, they're expending all these dollars. It looks like they're going to be moving forward. But this, again, is going to be the next part of this conversation. There's an opportunity there. If there's additional dollars and they're prioritized for that, that they could expand to additional local mental health authorities. Okay. So let's talk about the fellowships now and any internal changes there.
Very few. When there is a change, it's mostly to do with either positions not being filled in fiscal year 20, and not all of these budgets are finalized. But I do expect, as we talked about earlier, there's a couple of institutions we're going to have to think about, they're standing up programs now. How are we going to ensure they have the funding for those CAP fellows going into years 3 and 4?
Okay.
All right. So I'll go over to the request for additional operational funds. So we have one from Dell, we have several from UTRGV, and then one, I stuck in one for Tyler for those CAP fellowship positions, just as a holding spot for discussion. I don't know that we have the funds to be able to talk about that now, but it's just a holding spot. For Dell, they were asking for 4 LPCs if possible. So these would be a recurring cost. They thought that they exceeded their target goal for school participation. And so they wanted to be able to expand that clinical capacity to ensure they're able to meet the needs of the ISDs that they've signed MOUs with. And so here is the cost they're proposing for those 4 LPCs. And I think what, I'll walk through all of these, but I think, at the end, we need to think about what are our priorities? And because we do have some gaps in terms of what operational funds are going to be left, prioritizing these so that afterwards we can just easily allocate those costs out. So for UTRGV, they had one request related to CPAN. And this was for an additional 0.35 of an FTE of a child psychiatrist. They thought that would allow them to serve about 50 15% additional children through consultations at a cost of $123,000. And then for the CPW program, they were asking for 0.5 of a faculty FTE and an additional resident. And those would allow them to expand the services that they're providing to the local mental health authorities. And I don't know if we want to go into that one a little deeper.
Michael, you want to say anything about that beyond what I already said?
Yeah. So this goes back to originally we were working with one main LMHA in our area, and we got requests from 3 additional LMHAs that will cover our whole 13 counties. And these 3 additional ones, we would do it through telepsych, and this funding would allow us to be able to serve those LMHAs as well.
Okay. So if we did this, you would now be able to serve all the local mental health authorities in your geographic area.
Yeah, correct. There's 4 that span the 13 counties.
Okay. All right. Let's go on with the other requests. And again, this is looking at those ongoing dollars versus the one-time dollars. But go ahead with the next part.
With the proposals?
I guess the other one that we haven't talked through then was the, and you mentioned it, was the Tyler and fellowship. And in many ways, that fellowship dollars, that's next legislative cycle to obtain those dollars. Those fellows will not be in place until July of 22.
Correct.
Okay.
All right.
So my thoughts on all of those so far are those are very much in line with what the legislature said that we should do, whether it's expanding the TCHAT or CPAN or CPW. It looks like the ask is more than the recurring dollars thus far. Again, we can't make a final decision yet because we need to see UTMB's final budget and refine the other budgets. There may be some additional recurring costs that come out of that process. If there are, these seem to me to be very aligned again with what the legislature would want us to do with those dollars. Any comments related to that?
I mean, just to be the killjoy, that adds up to about 850,000.
Yep.
And when I'm looking at the program summary, if I'm reading this correctly, we've got about 242,000 in recurring costs. Am I reading that correctly?
That is correct. And so there would have to be prioritization, and following prioritization, if there are additional recurring costs, and so each institution needs to look closely at the recurring costs. If you're putting something as recurring costs, but you know that you're not going to hit those targets, here are some good opportunities to use those dollars with other institutions. Okay.
All right.
So we'll need to again, following this, prioritize these opportunities. Okay.
Now, there were some recurring costs that were associated with some of the technology pieces that Baylor was talking about earlier. And part of that has to do with data costs. I'm just going to bring up. We didn't get a proposal as such for these, but there was a project pricing sheet, if it'll allow me to drag over. And so although there is a one-off portion to some of these, there's also at the bottom some additional storage costs. And I think at the time that Dr. Williams gave this to me, she's still in discussions with TRAIT about the best way to handle storage. And so some of these numbers may no longer be accurate. So that's why I've put them in yellow. They may or may not be accurate. But the first piece on there was around that trait build out phase 2. And that was a cost of $82,000 that she went over earlier. The second piece was related to that TChat student screening tool. Now it looked like there was a recurring cost. And again, I don't know if that's still going to remain the same, but it talks about $15,000 a year for 100,000 users, unless the students end up getting referred to TChat. And then the third one was the EMR integration. And these costs, the recurring costs, will depend on the number of HRIs that choose to do that integration, but it was an ongoing cost of $5,000 per HRI to do the EMR integration, as well as sort of these upfront costs. So assuming that every HRI did that integration, we'd be talking about $100,000 for this year and then $60,000 moving forward.
And remind me, Lachelle, on the individual institutions' budgets, some put in that integration into their budget, right? Or how does those two things interact?
Yeah, I think the costs that people have put in their budget would be the cost that they would be paying directly to their EMR, not the trait costs, because there's a cost on both sides. And so it would be handling the cost they would be paying to their EMR provider. There would still be this trait side to it. The fourth one is around federated authentication. This is something that our security folks had recommended, and it's just a way to ensure that if a member of staff comes into the organization and leaves, you have kind of that single sign-on to the HRI system that will automatically disable that username and password. For the UT system institutions, that's Shibboleth. And I don't know that these costs, this $24,000 is accurate. It's $2,000 per integration, but I think it was per single sign-on, and I'm trying to get clarity on whether that would just be a single cost for at least the UT system institution, so that could go down. But again, this is more related to security of the system. So although you have the multi-factor, which is great, the single sign-on just helps. It's an additional layer of security. And then I just, as we were talking through it, added in the Wellnity, if that was something that we wanted to move forward, because it did sound like there was a recurring cost. So if we're talking about allocating recurring costs, I want to make sure we talk about it here. And then we had two proposals that were submitted. I don't think they made it out in the documents, but that's something that we can circulate afterwards. And maybe we can get Baylor and UT Health San Antonio to talk through their two proposals. Dr. Williams, are you the best person to talk through stepped care?
No, that would be Eric and I thought Steve from I thought they were working on it together. I don't know if Eric is on today.
I think Dr. Blader was very involved in that too.
Yeah, Joe and Eric worked on the learning collaborative, not the stepped care.
Oh, I'm sorry.
Joe's on. Joe could certainly talk about the stepped care. I mean, excuse me, the learning collaborative.
So let's skip to learning collaborative, and then I can bring up the document for the other one if we want to read through it.
Okay. So what Dr. Storch and I had been talking about and thought would be useful from the standpoint of not only workforce expansion, but potentially workforce enhancement, and is dissemination and heightened knowledge and proficiency in delivering evidence-based psychosocial treatments. Given the way the legislation was written, we would, the target audience was to be the psychiatric trainees who we get involved through CPWE. And we know that in fellowship, this is the time where they're really, really hungry for this kind of training. And many places don't have very strong or consistent infrastructure for providing training and skills in these psychosocial treatments. Not to say that this is something that we routinely expect that physicians would be doing in practice, but rather it's important for them to have a good understanding of the basic principles that underlie these treatments, what they might expect if they refer someone to access them, and also just in even in routine psychopharm treatment, it's often so important to have some understanding of behavioral principles and other techniques that promote therapeutic goals. We also wanted to make it available to the extent desired to the local mental health authority, who is partnering with each site in CPW. We got some feedback about making sure that what we were offering wouldn't intrude on some of the things or treatment frameworks that they're mandated to provide. And of course, we're very sensitive to that and would try to develop the curriculum in tandem with the LMHAs to make sure that their needs are met to the extent possible also. In other words, that would be involving their current therapy providers. We would love to offer the same information and approach to dissemination to them as well.
So the proposal had about $204K in staffing costs and $16K in other costs for a total cost of $262. I assume that these staffing costs are one-time costs.
Yeah.
Okay.
Yeah, it's mainly to develop the curriculum, any kind of supervisory or practice type of effort, case conferences, that sort of thing.
Okay.
And some outside materials, and if we have speakers who are the national experts on these topics, to engage them and then see how it goes and do some evaluation.
Did anybody have any questions related to this before we move on to the other one, the stepped care? Okay.
Danette Castle, do you have any thoughts related to that?
So I was just debating whether to take up time for the conversation, but we did talk about this in our work group. And I would say that there was a positive response to strengthening the training. And as long as it is in alignment with the rehabilitative, psycho-rehabilitative services that are provided through our system and required by the agency, and doesn't take away from any of the other initiatives, and we really supported it.
Okay, thank you.
All right. So it sounds like we maybe don't have a good person to walk us through the Baylor's CBT, the stepped care proposal.
Well, I mean, I'm happy to talk about it conceptually.
Go ahead,
I mean, I
Andy.
talked with Eric quite a bit about it. And I think Joe and others know quite a bit. And I don't know if Maduker's on or anybody from UT Southwestern. But when I talked to Eric about it, I mean, I think this is really important. I mean, basically, right now we cover primary care really well with CPAN, and we cover urgent care really well with TCHAT, but we don't really have a way to help people make sense of where do you go next, and to begin to sort of convey that to both the primary care practitioner who may be looking for a referral, as well as, you know, developing some protocols across the consortium members, both the HRIs and the LMHAs and other state public institutions, about, you know, what would sort of pathways look like. So, I mean, this is state of the art, and this is sort of one of the advantages we have by having folks like Eric, Joe, others in the network who, you know, really know these protocols well. And they would fit really well, I think, with some of the HRI's infrastructure. So it just seems like it's a way to maximize both the utility, the use, the expertise we have in the network, as well as the utility of our scarce specialty care resources. So I think investing in developing these protocols would both be a good sort of efficiency for now, but would also be a real value add, especially because you'd bring other HRIs and other folks into that discussion and really, I think, advance our understanding of those clinical protocols and how to implement them. So I from somebody who wants to see as much quality improvement as possible, this to me feels like a really, it's absolutely about maximizing CPAN and TCHAT value. It's not about creating specialty care. It's really about how do you maximize the value coming of those referrals and the directionality from the existing program. So I don't see it as outside the CPAN TCHAT bounds.
And Andy, can you talk about, you know, is this one-time costs or is this recurring costs?
As I understand it, and I'd have to, you know, I didn't do the budget there. I think these are one-time costs that would develop sort of that expertise over the next year and kind of amplify it. Now, there may be future opportunities to continue to improve that, but I think if you know, there's that would be a separate decision. I think it would be a stepwise decision. You would achieve some goals with just this investment. This is obviously an important line of development, I think, for the field. So, you know, certainly there would be other opportunities to develop too, but if you didn't pursue them, I mean, I think, you know, having one delicious cake is fine. Having two delicious cakes is probably better, but if you only had one, you'd still be happy to have one, I think.
Yeah. I just don't want to give somebody a delicious cake and have them expect that they're going to continue to get delicious cake and take away the cake.
That is a risk. And I think, you know, maybe that is just an assurance that if that happened, since Dr. Sorch isn't here, to just be able to, and if anyone else knows more about it, but you know, for him to just acknowledge that, and I think, you know, kind of consent for one-time cake eating, I think would be the way to think about it.
Well, another way to look at it, Andy, is that the goal is to help people learn how to bake their own delicious cakes.
There you go.
I like that. Teach them to bake cake. Don't just give them cake. I like that.
Which I like better than the usual fish analogy because I'm allergic to fish. So thanks.
All right.
All right. Let's see, jumping back.
So thinking through with the, Michelle, do you have anything else before we kind of bring it up to a high level again?
No, I mean, the only other one-off cost that I added in as we had our discussions this morning was that additional CAP fellow that Dell was looking to get funded.
Yeah.
We've got the funds for one-time funds.
So that can be one-time costs. And so, you know, again, if I was, you know, as I'm thinking through this right now, there's kind of three different decision points. One is within institutions, we have worked with them to try to make sure they can figure out how do they use their dollars based on the programs they have, and making just kind of redistribution within their buckets, CPAN, CPWE, TCHAT, et cetera. And we feel comfortable with those type of decisions, with saying, we bless them, go forward. And I guess maybe an approval from this group related to that strategy would be helpful. Then we have the issues of recurring costs. And it's a little bit hard to make those final decisions until we get all the budgets in, and after a couple of institutions do a final refinement of their budget. And so we will pull, we're not going to accept any more of these right now. I think we need to say we got the proposals that we want to consider. We can start working on prioritizing them, but I can't say what we're going to fund yet until we know how much money is in that's going to be made available. Third kind of decisions here are with one-time costs. There's actually quite a bit of one-time costs. However, even with that, I think we have to be careful that the legislature knows that we're trying to be really good stewards of the dollars that they allocated to us. We want to make sure that what we do is aligned with the legislation. But where we can do that, those are easier calls because there are dollars that are available. And so, as long as they are really aligned and there's support from the overall consortium, that these are going to enhance CPAN, TCHAT, CPWE, or the fellowship programs. If they are aligned there and this group approves them at the next meeting, then I would feel comfortable with moving those forward. But there's three different conversations that are taking place, and they get intertwined, but I think we have to pull them apart. Does that make sense to the group? And I guess along those lines, if any of these recurring programs could be done through one time somehow, talk to us so that we can kind of think through that a little bit. At the end of the day, I don't think we're going to have plans for all the one-time costs. That was basically from this last year. We may end up giving some dollars back. That's not the worst case scenario with the legislature and everything that's going on right now. Again, I think that's what will be a demonstration of us trying to be a good steward. However, also, if there's smart things that we can do that are going to expand these programs right now, I think those are very germane, and the legislature would want us to do that. So let me stop there and see if there's questions.
Going. Could you just go on the proposal tab there, Michelle, for a second? So for instance, the Learning Collaborative, we've got that amount, the 262, we put that as a non-recurring cost under our CPWE. Do I take it here, we should wait until, I guess, we all approve that? And if we decide, no, we're not going to do that, then is that 262 goes back in the pot? Is that the philosophy? Or is that 262 sort of, that was part of UT funds, or were in the San Antonio pot originally, right?
Yeah, I think, Steve, at our next meeting, I don't see that as being a problem. And so I think at the next meeting, we can have that final approval and use the lapsing one-time funds to be able to do this one-time project. Does that answer your question, or did I miss it?
I believe it does, yes.
Okay. Okay.
And I think in some instances, like the stepped care proposal, assuming everybody's on board with that, Baylor currently has the funds available to them to stick that within their budget as it is right now, because they're giving back 1.3 million.
We may want some of that build out cost for some of the technology pieces. So, so I would, as I said, I think prioritization gets back in there because, if we're going to build out TCHAT, not the screening tool, but just TCHAT, I do have the funds to do that within the current budget. And then we've talked about some of the repricing for the storage piece of it. So
we will be probably requesting for CPWE some build out of trait as well. So I imagine that's going to be another 30 to 60,000 would be my guess.
So give us some feedback related to these proposals. And again, our team will work with your institutions to get a final proposal that we can bring to this group at our next meeting. But your input right now would be very helpful in that. And again, we'll send out more information to help you prioritize things for us. But at the next meeting, I think we need to give final approval for how any lapsing dollars will be reallocated.
And I just want to add that it's really important. There's an assumption here about expected spend in fiscal year 20 that needs to be validated when you give us your quarterly reports. So the sooner you get those quarterly reports to us that include your actual spend for this fiscal year, that'll help me know what's truly carrying forward to make sure that we're retaining the right amount of funds for you.
So in our limited time, go back to the recurring options. I'd like to hear how these resonate with you and any concerns, et cetera, so that we can use that in working through how do we prioritize these. So Dr. Nemiroff, let me ask you a question. So you have 4 LPCs there. As you've heard this conversation, there may not be enough recurring funds available. If there's not, is there a way to do part of that and come back at another time to try to figure out how do you expand to the other schools?
I'm sure the answer is yes, but Dr. Coley, I'm looking at her, so you could answer as well.
Sure. Dr. Lakey, I do think that we could figure out a way to do less than those 4 LPCs. I think the 4 LPCs would be ideal just with the number of LMHAs that we're contracting with. As our proposal indicates, we've just exceeded the number of schools that are already engaged, and we're still working with a few other school districts. So I think the additional LPCs, whatever funding there is that's available, would just help us to enhance our TCHAT services.
No, I really appreciate it. And I appreciate the great work that you guys are doing and enrolling schools. I'm just, again, trying out of a lot of good things, trying to figure out how do we do the best that we can.
Sure.
So let me then go to Dr. Escamilla. You have 3 different things here.
Yeah.
2 that are related to the local mental health authorities, the other related to CPAN. If you were to prioritize those 3, how would you prioritize them?
Yeah, I think, so the one with CPAN would be the lowest priority for me, because we're already doing CPAN, so it's just doing a little bit more there. But I think the higher priority I would suggest are the working with the LMHAs. And although it says like 1 resident FTE, that's actually spread. So there's a portion of the FTE that goes to the 3 sites. So I think, I just think that would be a good use of the funds to spread this work throughout the 13 counties. So that would kind of be my priority. Maybe if you had to prioritize within that, maybe the faculty time followed by the resident time. And then again, I think the CPAN is really just optional if there's money left over, which there's not going to be. So
okay,
not a big thing.
No, I really appreciate it. So I guess another kind of follow up. How many additional local mental health authorities were you planning to partner with?
It's 3 different ones. I could name them, but
yeah.
Yeah.
So if we can't do all of this, if maybe we can get 25% of an FTE and a half of a resident, would that work, or is that not doable?
We'll do what we can. So anything would help.
Okay.
Yeah.
All right. No, I appreciate your guys' honesty. And again, we're going to try to do as much as we can, but don't think we can do all of it. And we're going to need to prioritize not only between different groups, but within each of these groups, if there's ways to refine it to exactly what we can do, that's going to be very helpful.
Yeah, I think just to follow up on those LMHAs, if we don't get all those funds requested, I'd still try to keep a footprint in each of them, just less hours that we're doing. So we'll still try to include them.
All right. So then let's go to the other proposals. And again, Lachelle, kind of focusing on the recurring costs in the other ask. And again,
And these may change depending on how many HRIs are involved, how many integrations, and then as Dr. Williams was talking about, the data retention costs, data storage. So I don't have a high level of confidence in how accurate these are right now. But it sounds like Wellnity at least is pretty solid.
okay.
I would definitely prioritize personally Wellnety over other things because it is about helping get all of our resources, whether it's Birth or Wellnety. I just meant some kind of database for resources that both CPAN and TChat teams could utilize.
Mm-hmm. So how would you prioritize the rest of those?
So yeah, again, once I saw the sort of mounting costs for EMR integration, I wasn't personally in favor of it at that point, at least not right now. It may be something to look down the road to, because again, as Lachelle pointed out, there is both pass-through costs that Trait would be needing funding for, and then each HRI themselves. And so I'm not sure that it's a necessary step maybe right now.
Mm-hmm. And then again on the build out versus student screening, would you put the build out? The build out is one-time cost though, right? So that's an easier thing to do than the recurring costs for the student screening.
But again, I would
well,
add
again, the recurring costs have more to do with data storage, and that's where Lachelle and I are talking about. We don't have confidence yet that we have the correct numbers to share with people.
And is there a way to buy that out several years versus having to pay for it 1 year at a time?
That's one of the things we're going to explore based on, yes, we're going to look at that as well. We're trying to come up with some more efficient ideas since things keep getting added to Trait to store. We're wanting to make sure we're good stewards of the dollars.
And then I guess the same thing with the federated authentication. Is there a way to buy that out for 3 or 4 years versus having it as a year-to-year charge?
That I would need to go back to both Lachelle and the Trait team, and then some of the HRIs to find that out.
Okay.
We'll look into it a little bit further.
All right. No, I appreciate that. I think as much of that we can think through, how do we prioritize within each of these institutions, and how to do part of it. If you can't do all of it, will help us figure out how do we spread those minimum dollars to its best advantage.
So assuming we can get the dollars correct and matching with the available budget, is everybody happy with the options laid out here?
So then again, kind of process wise, I'm going to ask the people that put in proposals to, just like the legislature used to always ask me, go back and sharpen your pencil and figure out, how do you prioritize and what it really is. And, if there's ways that you can do it with one time versus recurring, come back with that. And we will try to figure out with that and the feedback that you're giving us right now, how much of that recurring cost projects we can do, and then bring back to this group a proposal that will get refined during our meeting, but we'll need to vote out at the next meeting. And then Andy, on the step care, is that scalable?
My understanding.
Yeah.
Go ahead. My understanding from talking to Eric is it's totally scalable. I mean, I know he talked through several different scenarios, and so I think what I understood in his proposal, again, this is just based on my discussions with him, was that he was saying this is the maximum we could do to get to the most HRIs possible. I think if it would probably be a smaller number of HRIs, or maybe there would have to be matching or some other funds to have the number of HRIs. But I know he looked at several models that were much more focused, that were kind of, started with maybe 2 or 3 ready and able, institutions. So I think that's probably where it would be, the fewer partners. That's my understanding, but I know it's scalable, and I'm sure if you talk to him, he can say it better than me.
Okay. All right. Any other comments from the whole group?
Just managing expectations around FY21 budget transfers. We have to finalize this before we can give the coordinating board instructions to transfer those funds.
Okay. Yeah, so I think, again, we have a little bit more work to do. We need to complete that at the next meeting and have everything finalized. Again, apologize that we can't do it now, but a hurricane thrown into our institutions made it a little difficult to have final numbers. And so we will work with those institutions to get their final numbers. Again, we'll, with that, pull out how much money really is available. And I think come to this group with a proposal related to how we can maximize as many of these things as we can with the dollars that are available. Does that seem like a reasonable plan to everybody?
It does.
Okay. All right. Well, folks, that's all I have on my agenda. Is there anything else we need to talk about today? Hearing none, I appreciate everyone's time. Do I have a motion from somebody?
Move to adjourn.
I have a motion. Do I have a second?
Second.
All right, all in favor?
Aye.
All right. Thank you all. I'll talk to you soon.
Bye.
Bye.